I did reach out to the other instructor, as I promised you guys, the nurse practitioner, to see if she can come in and do some stuff with us, but I'm not sure that that's going to happen yet, but I'm working on it. Okay. Why is that stopping? Do I have the right one up? No, wrong one up. Okay, I think we're good now. Let me change this share over, and then we should be good. Okay, you guys can see my screen okay? You need to make me to make anything bigger?
We good.
Okay, so we're talking about the postpartum period. What kind of changes are going to happen in mom? This is ridiculous. Okay. Try this again. All right, so during this transition period, okay, we're going to see a lot of both physiological and psychological changes. Some of the changes for mom are going to be about, now everything's about the baby, right? Not about mom anymore. And that's where it really starts. The baby's born now, so we're in this puerperium period, which is going to be the last 6 weeks from the time that the placenta is delivered until mom sees that physician for that first visit. All right, so psychologically, if she had a really fast birth, she's going to have a lot to deal with, because now things just suddenly flipped over, and it's not about the baby, it's not about her anymore, it's all about the baby. So during pregnancy, everything is all about mom, right? Mom has a backache, mom needs something to eat, we're going to put mom's feet up, we're going to help her out. But now the baby's born, so everything is about the baby. So in that first beginning stage right there, mom is going to be dependent on you for a lot of things: her food, her fluids, her nutrition. Okay. The body is going to start to go back to that pre-pregnant state. Changes are going to happen cardiac wise, changes are going to happen with hormones, changes are going to happen with the breast here, and changes with the period and all that, and ovulation. Okay, so you have to know what those changes are, because you have to know what's normal versus abnormal, so that if something's going wrong with mom, you'll be able to jump in and help out. So the taking in phase, that happens right after birth. You have to know these. During the first 24 to 48 hours, the characterization of this is the dependent behavior. Okay, again, mom needs to rely on you for everything: foods, fluids, decisions. Okay, then we have that taking hold phase, and that is characterized by both dependent and independent behavior. So mom has been dependent so far, but now she's going to start to show a little interest in the baby. She'll start to take control of her body, and she'll start to worry about both her health and the baby's health. She'll start to care for the baby, and you'll start to see her increase her participation, and in not only her own body functions, but those of the baby. She'll start to want to take charge and support the needs of the baby and move away from others. So she's now going from, she's still partially dependent, but she's going from that dependent to that independent stage. And then the letting go phase, and where she's going to reestablish her relationship with others. She reestablishes her relationship. She's adapting to parenthood. She's taking on that new role as the mom. She's going to take responsibility for the care of the newborn. And now she recognizes that she's going from that original symbiotic relationship that she had during pregnancy to a lifestyle that now includes one with the baby. So now she'll get rid of the fantasy that she has, and she'll accept the realization that the baby is now here. Let me see if I could get this camera off of me. I don't want the camera on. Sorry, guys, but I just don't want it on. All right. So now we're in the reproductive phase. What kind of changes are going to happen with that? Okay, so we have involution, right? The muscles are going to contract, and we're going to regenerate the uterine epithelium. So after birth, we're going to have this shedding of the placenta. That's going to lead to uterine involution. Okay, it has, there's a lot of tissue there that has to be destroyed. And then the body is going to start to repair and remodel that uterus, because we want it to go back to that globular shape that it had pre-pregnancy. The menstrual cycle that was interrupted during pregnancy will now start to return. That won't happen for several weeks after childbirth, okay? Especially if the woman's not breastfeeding. The ovulation will then return in time, okay? And it could return before the menses cycle. Breastfeeding, so then with the breastfeeding, like some people think that that's a safe alternative to keep them from getting pregnant, but it's really not, because the ovulation could actually return before the pregnancy. All right, so they should be using a second form. So this is what you really want to be reinforcing. Technically, we're telling these people no sex, okay, for 6 weeks, right? Or until you go get your checkup. But realistically, that may not happen. So you have to protect them from getting pregnant again, or trying to protect them from getting pregnant again. And then we want that uterus to go back to that pre-pregnant size. So the uterus weighs about a gram right after, about 1,000 grams, I'm sorry, right after the baby is born. And then involution is going to take it back to that smaller size. It's going to shrink it in size as it contracts, as it destroys that tissue, okay, and it goes back to that globular shape. So about a week after birth, it'll be about half of its size, and then by the time 6 weeks goes by, it goes back to around 2 ounces or 60 grams, which is the size that it was before pregnancy. So those muscle fibers that contracted and stretched during pregnancy will also start to shrink. Catabolism will shrink the enlarged myometrial cells, and then we'll have regeneration of this uterus epithelium from that lower layer of the decidua, and the upper layers are being sloughed off and shed. That's part of that lochio discharge. So that's what's happening as we're discharging that lochia. It's removing that shedding of that endometrium lining. The cervix is now going to close, and it's going to look like a jagged slit. All right. Eventually, the thickening of the vagina will go back to normal, and we'll see the return of the rugae. Right after birth, the cervix starts to extend into the vagina, and it will remain partially dilated, bruised, and swollen. And then it will start to return to that pre-pregnant state by the end of week 6. It will gradually close, but it never goes back to its pre-pregnant appearance. So once you're pregnant and it changes to this appearance, it's going to stay in that appearance. It doesn't go back to the way it looked before pregnancy. Right after childbirth, it'll be shapeless and swollen and distended for several days. All right. And then it'll start to gradually close, go back to that normal state, as close as it's going to go by 2 weeks. and then the external OS itself will widen, and that's the part that will never be the same after birth. All right, so it's no longer shaped like a circle at that point as on side A. Once pregnancy happens, it's now going to look like side B. The vagina is going to be edematous as well right after birth, and it'll be relaxed. The ovarian function will go back to normal as the estrogen production resumes. The mucosa will start to thicken and the rugae will return back in about 3 weeks. In this stage, the vagina has kind of a gaped opening and it's relaxed, and that's part of that relaxin. Remember that helps the body to relax during pregnancy so everything can open up and stretch for the baby to be born. So now it's all going to come back together. All right, so about 6 to 8 weeks, that vagina will go back close to its normal shape. It's still going to be a little larger than it was before pregnancy, but it'll be close. The normal mucus production and the thickening of the vaginal mucosa will return with ovulation. Put on mute, please. You put on mute, please.
I'm sorry.
Thank you. Can you go on mute, please? So we have this re-thickening. Remember, the vaginal wall and everything thinned out. Okay, all this for pregnancy. Now it's going to re-thicken. It's going to start to decrease in size, regain that tone. All right, and it's going to be restored by about 6 to 8 weeks postpartum. We may have some dryness and some dyspareunia or coital discomfort during this time until menstruation comes back. So if they're going to have intercourse during that time, they can use like KY jelly or some other water soluble lubricant to decrease the discomfort. That perineum that stretched out during childbirth might still have some trauma, okay, and it can be painful. So we have to consider that, all right, especially if the lady has like an episiotomy and if she has anything like hemorrhoids. So you need to address this pain that they're going to have in this area after birth, because it can be very painful, especially if when they do the episiotomy, somehow it goes down towards the anus too far. Sometimes they can cut those muscles and stuff there, and it's extremely painful for the woman. Muscle tone may or may not return, and that depends on how much injury there is to that muscle and nerve in that area. Okay, so if it does extend to the anus, it's going to be a lot more painful and discomfort for the lady, especially if she has to go poop or if she wants to ambulate. And she might be scared to even try to poop because knowing that, you know, this episiotomy is down that far now, and she might be afraid of either pain or ripping the sutures out. We can use things like ice packs, warm water over the area, using peri bottles, witch hazel pads, and sitz baths to relieve the pain. The major thing after the fact is going to be those Kegel muscles, okay? Those Kegel exercises to return that pelvic muscle tone back to normal, okay? Because if that pelvic muscle tone doesn't go back to normal, then it can lead to urinary incontinence in the lady. All right, so we want to make sure that we're teaching them how to practice those Kegel muscles, all right, to improve pelvic floor tone, strengthen the perineal muscles, and to promote healing. So that's what you're doing as the nurse there. All right, so following statement, true or false, after birth, the cervix returns to pre-pregnant shape.
False.
Okay, good. False. It doesn't, right? After delivery, the cervix closes, but it never gains its pre-pregnant appearance. It will no longer have that circular opening, but it will appear as a jagged slit-like opening. All right, cardiovascular. So what's going to happen here? The blood volume is going to drop rapidly after birth, and cardiac output is going to be high. And that's going to make the woman a little bit unstable cardiac-wise, okay? First, it'll slowly decrease. And during the birth process, depending on whether she gets a vaginal delivery or a C-section, she'll lose anywhere between 500 and 1,000 mLs of blood loss. 1,000, we would expect to see more with the C-section. So we're going to have these dramatic changes. It can cause cardiovascular instability. Okay. During the process of pregnancy, the heart is slightly displaced up and to the left because of the baby. All right. And the uterus going, pushing up on it. After birth, remember the uterus is going to go into that involution process. It's going to shrink in size, and it's going to start to descend back towards the symphysis pubis. So when that happens, the heart is going to now start to shift back into place. So the cardiac output will be high for the first few days, and then it will start to decline slowly. Okay, blood volume will increase substantially during pregnancy. Then it will drop rapidly after birth, and then it will start to slowly return back to normal, which will take about 4 weeks. While that's all happening, the hematocrit level should remain stable, okay? And this is going to happen because the body is going through hemostasis as those blood levels are changing. If you do see an acute change in the actual hematocrit, okay, then that could indicate a hemorrhage. We wouldn't expect to see that. The decrease in that cardiac output and blood volume is mostly from that blood loss during birth, okay? And then the output would decrease to the pre-labor value about 24 to 72 hours after we give birth. And then over the next 2 weeks, it's going to go down and go back to that pre-pregnant level over about the next 6 to 8 weeks. Again, the hematocrit level would be stable. It might even increase during this time because of the loss of that plasma. We'll see an acute, if we see an acute decrease in the hematocrit, it's not an expected finding, and we should look for a hemorrhage. Bradycardia, we'll see, okay, in this woman. Postpartum, we should expect to see a low heart rate, okay? And that's because the increased blood flow going back to the heart and central circulation that is no longer perfusing the placenta will cause an increase in central circulation, an increase in stroke volume, and allow a slower heart rate to provide ample maternal circulation. Then gradually the cardiac output will go back to that pre-pregnant state about 3 months after mom gives birth. So we have this pulse rate that will decrease, okay? And it's reflected in bradycardia, sometimes between 40 and 60 beats for up to the first 2 weeks postpartum. And then if we see tachycardia above 100, we have to investigate that because that could also indicate hemorrhage. Blood pressure mostly falls the first 2 days. And that's because of what? Hello?
I'm sorry, say it again, Miss Sue.
Why will the blood pressure fall in the first couple days?
It could be a sign of bleeding.
The bleeding.
No, it's going to fall in the first couple days because
normal.
of birth, right?
It's normal.
You're going to lose 500 to 1,000 mLs during that birth process. So that's why it's going to fall in those first 2 days surrounding that birth process. And then it's going to gradually increase for the next 3 to 7 days. And slowly it will start to go back to that pre-pregnancy level in about 6 weeks. A significant increase accompanied by a headache could indicate preeclampsia and requires further investigation. Decreased blood pressure, a significant one, could indicate infection or uterine hemorrhage. So you're looking for that 500, 2000 ml loss right around the pregnancy, right around the birth of the baby. Okay, if it's significantly more than that, or if the blood pressure goes up, then you have to look at other causes. Okay, so if the blood pressure goes significantly up and they have a headache, we're looking for preeclampsia. If the blood pressure significantly decreases beyond that 500 or 1000 mL, then we're looking at a potential infection or a hemorrhage. You have to recognize that a decrease in blood pressure and cardiac output are not expected changes in the postpartum period. So we have to identify and make sure that we make a prompt intervention if we see something like this occurring. All right, coagulation factors. Those have changed, okay? And about 3 weeks after we have the baby, they'll go back to normal. And these are important, okay, because we have to think about blood loss at childbirth. What kind of things can make the woman higher at risk? And those are things like smoking, immobility, postpartum factors like infection, bleeding, emergency surgery. So we'll see physiological changes of pregnancy, which include hemostasis that favor coagulation. So while we're pregnant, right, this woman is going to be in more of a hypercoagulable state because of what is happening with the vessels. Then there's going to be vessel damage during birth, and mom is going to be immobile. So those together is what puts her at risk for those DVTs. It talks about both the lower extremities and the lungs, because if the DVT were to break off and travel, then it's going to become what?
Blood clot,
Embolism,
pulmonary embolism,
A
or
pulmonary embolism, right. So then we have to think about the lungs. All right, so because the clotting factors increase during birth and they tend to remain elevated during the postpartum period, that is what causes that hypercoagulability. All right, so those coagulation factors are going to stay elevated for about 2 to 3 weeks after the baby is born. So remember, that hypercoagulability, along with the vessel damage that occurs during birth and the fact that mom is immobile, is what puts her at risk for these DVTs. The red blood cell production will cease early in the puerperium period. When is the puerperium period? Anybody? From the time that the placenta is delivered until 6 weeks, right? Hello?
Yes, Miss Sue. Yes.
Nobody out there? If you guys aren't engaging, you won't learn, I promise you. Okay, so the hemoglobin and the hematocrit levels are going to decrease slightly in the first 24 hours, but remember, they're going to remain stable. During the next 2 weeks, the levels will rise slowly. The white blood cell count will increase in labor and remain elevated for 4 to 6 days after birth. But then about the 6th day, it's going to drop back down to the normal level between 6 and 10,000. That can complicate things when we're looking for infections in the postpartum period, because we know that normally the white blood cell count is elevated. So now if someone has an infection, how do we determine if it's part of the normal process or if they have an infection? Is the following statement true or false? The drop in maternal blood volume after birth leads to a similar drop in hematocrit.
False.
False.
should-
How's the hematocrit going to remain?
It should be stable, or if it's decreasing, then we should look for hemorrhage.
Okay, it's going to remain stable with a very slight drop the first couple days, but then it's going to start to rise and it will remain stable throughout the postpartum period. The urinary system, what's going to happen with that? So during pregnancy, the GFR, or the glomerular filtration rate, and the renal plasma flow will increase significantly. But after birth, within 6 weeks, they'll come back to normal. The bladder will return to a normal tone, and the normal size and function, the ureters and the pelvis, all of which are dilated during pregnancy, will now come back to their normal size. The sensation of voiding could be affected by things like a laceration to the perineal area, swelling and bruising of the perineal tissue, hematomas, decreased bladder tone due to some sort of anesthesia, decreased sensation of bladder pressure because it's swollen, or because we have poor bladder tone, or maybe because it's numb from the anesthesia that they gave me during labor. So anticipate that after birth, okay, the woman is going to have a decreased sensation in that area of the bladder. She may not feel the need to void. So you need to monitor that bladder for distension, okay? Make sure she's not having any urinary retention. Again, things that could complicate that are perineal lacerations, swelling, bruising, tissue damage, okay, decreased bladder tone, and anesthesia can all affect her ability to urinate. If she has urinary retention, it could lead to bladder distension and a urinary tract infection. Also, in addition to that, the bladder can cause the uterus to be displaced, and the uterus can't contract properly. And so we end up with either uterine insublution, and that's going to be because it can't contract properly. All right. Uterine atony would be the major issue here. And that would cause excessive bleeding or a hemorrhage. So you're measuring the urine output. You're concerned of anything less than 150 mLs. Okay. Postpartum diuresis will occur. You'll have large amounts of IV fluids that you're going to give during labor. After the baby's born, the oxytocin levels start to decline, and there's going to be a decrease in the antidiuretic effects and retention of extra fluids that we were accumulating during pregnancy. There'll be a decrease in the production of aldosterone. Remember, aldosterone regulates both sodium and water in the body. So that will cause a decrease in sodium retention and an increase in urine output. The bladder will fill rapidly within 12 hours of birth, and diuresis will begin within 12 hours after the baby is born. And that will continue for the first week postpartum. And then within a month, the normal urinary function will return, and the aldosterone, the ADH, will start to go back to its normal function. The GI system will also go back to its normal function. Give me 1 second here. Okay, so the GI system will go back to its normal function right after birth, because the uterus is no longer in that area, putting pressure on those organs. So it's going to start to go back to normal. You may have a decrease in bowel sounds, okay, right after the baby's born. Why?
Does the peristalsis decrease?
Why?
The shifting of organs during the delivery process.
More so from the, it will be partially because of that, okay, and partially because of the anesthesia and stuff that we're going to use during the birthing process, right? So it's a couple of things that will cause the peristalsis to slow down. All right, so for about 3 days, okay, after about 3 days, everything as far as the bowel sounds should start to go back to normal. Okay, the progesterone levels are going to go down. Those were increased during pregnancy, and they caused some of the muscles in that area to be diminished or decreased, the muscle tone to be decreased, and that decreased the bowel sounds or diminished the bowel tone. Also, besides the analgesics, the surgery itself, the diminished abdominal pressure, the low fiber diet. Remember that mom's not taking in as many fluids during this time. So that also will contribute to it. So we're going to have constipation as a problem. And we want to give them a stool softener. And why do we really want to give them a stool softener during this time besides the issue with the constipation? What other issues do we have to take into consideration here?
If they have an episiotomy, so you
Right.
don't want them to stress.
Right, if they have that
that-
episiotomy. So, you know, if they're straining, they have sutures down there. And most of these women are going to have hemorrhoids because they've been straining throughout pregnancy. And that's a common complication with pregnancy, is having those hemorrhoids. And then after birth, mom's going to be hungry and thirsty. Now, remember, right after birth, what phase is she going to be in?
What do you mean by stage, Miss
What phase?
Sue?
Is she going to be in the taking in phase, the taking hold phase?
The taking hold because she'll be tired.
The taking in phase, right?
In, yeah, I'm
Taking
sorry.
in, and she's in that dependent status now, right? Because that's the characteristic of that. So remember, when I'm in the taking in stage, I need to be taking in foods and fluid and rest. And the nurse needs to be giving them to me because I'm in a dependent mode there. All right, so you have to anticipate her needs, okay, as far as food and fluids. And you're going to give that to her as soon as she gives birth, as soon as it's safe to do so. Remember, if she had a C-section, she may have other anesthesia that you have to monitor to make sure it's okay for her to eat. But once that you've cleared all that and it's okay for her to eat, then you're going to start providing these fluids and foods for her. All right, musculoskeletal, okay? So during pregnancy, all right, there's going to be some musculoskeletal changes, things like increased ligament laxicity. Why?
It's because of the stretching.
Okay, good. We're going to have weight gain because of the
Okay.
baby growing. There's a change in the center of gravity. What does that mean?
Everything shifts because of the pregnancy.
Okay, so the body has to stabilize itself. Otherwise, mom will be flipping back and forth like a little penguin. All right, and carpal tunnel syndrome all will revert back to what it was during the postpartum period. Hormones, relaxin, estrogen, and progesterone all relax the joints. After birth, those levels are going to decline. So the relaxin will go down, the estrogen will go down, and the progesterone will go down. This will cause all of the joints to go back to the pre-pregnant state, with the exception of the feet. Sometimes what we'll see here is the woman will go back to her previous shoe size, or she'll go back to a larger shoe size.
Is it because of the vein or the swelling during the pregnancy?
So those joints stretch and grow a little bit during those pregnancies. They grow by widening.
Oh, okay.
So the feet become wider, probably to give her a more stable surface area. Because remember, we have that shift in the gravity. So if the feet are widened, it will help her to keep from tipping over, right? Maintain her stability. So because of this, the feet are not going to go back to the normal size. So most likely she may end up in a shoe that's a little bit bigger size, permanent. All right, so also fatigue, activity intolerance, distorted body image is all going to be after birth. And this is because the relaxin continues to decline, and so do those progesterone levels. That can cause hip and joint pain, and especially when they're ambulating or exercise. So during that time, we have to stress good body mechanics and correct positioning. This will help the mom eliminate low back pain and any injuries to the joint. And then in about 6 to 8 weeks of delivery, everything comes back and the joints are now more stabilized and they're going back towards that normal state. During pregnancy, we're also going to have stretching of that abdominal wall, okay, to accommodate that baby that's, and that uterus that's growing. And that will lead to a loss in muscle tone, and it could cause a separation of the longitudinal muscles, the rectus abdominis muscle of the abdomen. That's called Diastasis Recti, and it's more common in women who have a poor muscle tone in the abdominal area before they become pregnant. After birth, muscle tone will be diminished. The abdominal muscles will be soft and flabby, and specific exercises may be necessary to help the woman regain muscle tone. If they do develop the diastasis recti, which is again that separation of those longitudinal muscles in the abdominal area, it can be repaired a lot of times or improved with that exercise. When would we not recommend doing these abdominal exercises after birth?
C-section, maybe?
Yeah, she has a C-section. We might want her to wait for a little bit before she starts these. And then I would be thinking about what is normal. So normally after somebody has abdominal surgery, we would probably want them to wait anywhere between 4 and 6 weeks, depending on what the physician says. Excuse me 1 second. Oh, let that go to voicemail. That's okay. We'll call him back. Okay, so other things, as the estrogen and progesterone levels decrease, okay, the dark pigmentation on the abdomen, we'll get that Lena nigrea, and on the face, we get the melasma, which is that brown fading, and the nipples also will start to fade. Also, women are going to lose hair during this time, okay? They have a lot of hair growth, but because of the high estrogen levels during pregnancy, an increased number of hairs will go into a resting phase, and that's part of that hair loss. As the estrogen starts to return to normal levels, the more hair will start to fall out, and it's a temporary hair loss. After about 4 to 6 months, that hair growth will start to return. Respirations. So these are usually within the adult normal range. As the abdominal organs go back to their pre-pregnant state, the diaphragm also goes back to its pre-pregnant state. So changes in the thoracic cavity and the rib cage that were seen during pregnancy will now start to go back to normal. About 1 to 3 weeks, okay, we'll see the tidal volume, the minute volume, the vital capacity, the functional residual capacity, go back to those pre-pregnant values or state. Also, any shortness of breath or rib aches and pains that mom might have had should now be resolved. When that placenta is delivered, there's going to be a decrease in the placental hormones. The endocrine system will undergo several changes right after birth. So we'll see circulating estrogen and progesterone drop quickly once that placenta is delivered. The decreased estrogen levels are associated with breast engorgement and diuresis of the excess fluid that's accumulated during pregnancy. After birth, about a week, the estrogen will then be at its lowest level. And then it'll start to increase again about 2 weeks after birth. If the woman is breastfeeding, it will stay low until the breast frequency feeding start to decrease. The human chorionic gonadotropin, or HCG, and the human placental lactogen, progesterone, will all decline rapidly after birth. HCG will be non-existent after the first week, and the lactogen will be undetectable within a day after birth. The progesterone levels after 3 days, no longer detectable. And then production is reestablished of the progesterone when the first period returns. Prolactin, which is a hormone that is released by the anterior pituitary gland, will now become involved with lactation and reproduction. The prolactin levels will start to decline within 2 weeks if the woman is not breastfeeding. But it will remain elevated if she is. Give me 1 second, guys. Hello? Good, I'm in the middle of tutoring. What's up? Remember, you got to use that RN that's right above the 2013, that RN folder. Yeah, but you don't, for the folder, you have to click on that, and where it says RN right above the 2013. Yep, if you could give me till about 11, then I could jump on the Zoom with you. Right, but you didn't save it there. You saved it under a different folder. You didn't save it there. You saved it under a different folder. Can you give me till about 11 and then I'll try to Zoom with you? Okay. All right. You're welcome. You too. Bye-bye. Sorry, I'm IT. You guys know that, right? Okay. When people can't do anything, I'm IT. All right. All right, so the progesterone levels are going to be undetectable after about 3 weeks, and then the production will be reestablished with that first period. And again, the prolactin is secreted by the anterior pituitary gland, so it's involved with lactation and reproduction. Those levels will start to decline for about 2 weeks in the woman that's not breastfeeding, but remain elevated for the woman that's lactating. Okay, so during lactation, we have the secretion of breast milk. It's brought about by the progesterone, the estrogen, the prolactin, and the oxytocin. And it usually appears within 4 to 5 days after birth. We have a process that's known as the breast crawl, and this is what is skin-to-skin contact. All right, during the first hour, they lay the baby on the mom's abdomen, and the baby will instinctively start to move up towards the breast. Okay, and it's called the breast crawl. It helps initiate breastfeeding. So the baby is left undisturbed, skin to skin on the mom's trunk after birth, and the baby will start to move towards the breast. They'll start to locate and self-attach for the first feeding. Sorry, I got something stuck in my throat. The newborn will use legs and arm movements to propel themselves up. And once they reach the area of the sternum, it will bounce the head up and down, side to side. As the baby starts to get towards that nipple, the mouth will open. And after several attempts, they'll be able to latch on and start sucking. They have skills that enable early initiation of feeding at the breast. As the nurse, you can help promote the breast crawl as a continuation of the birthing process. You have a responsibility to promote the health of the childbearing family and provide evidence-based care. Encouraging the breast crawl can be the first step in health promotion for every newborn. The breast milk production can be summarized as follows. So first, we have an increase in the prolactin level at the end of term and a decrease in estrogen and progesterone. Then the estrogen, progesterone levels will decrease after the placenta is delivered. The prolactin is now going to be released from that anterior pituitary gland, and that's going to start that milk production. Oxytocin is released from the posterior pituitary gland, and that will promote the milk letdown. The infant will suck at each feeding, and that will continuously stimulate the prolactin and the oxytocin. During the first 2 days after birth, the breast should be soft and non-tender. Mom may also report a tingling sensation in both breasts, and that is that letdown reflex that will occur either before or during the breastfeeding process. The breast will start to change depending on whether or not the mom is breastfeeding or taking measures to try to prevent that lactation. So if she's taking preventative measures to prevent that lactation, then hopefully she'll also be able to prevent the engorgement as well. All right, so engorgement usually happens about 3 to 5 days after birth. and it will start to subside within 24 to 36 hours if we use the appropriate measures or treatment. This can happen in either mom, although it's probably more likely to happen in the mom that's not breastfeeding, okay, because she's not letting that milk down. So this is going to cause tender, swollen, over-distended breasts. And it can occur from either infrequent feeding or ineffective emptying of the breast. It usually lasts about 24 hours. The breast will increase in vascularity and swell in response to the prolactin 2 to 4 days after birth. If engorged, the breasts are going to be hard and tender to touch and uncomfortable. Frequent emptying can minimize the discomfort and resolve the engorgement. Standing in a warm shower, applying warm compresses immediately before feeding will also help soften the breasts and nipples in order to allow the newborn to attach more easily. Treatments to help reduce it include both hot and cold applications. Cabbage leaves. Tea bags I don't see on here, but they do use those also. Breast massage, expressing the milk, ultrasound, breast pumping, and anti-inflammatory agents. A non-prescription anti-inflammatory medication can also be taken for the swelling and discomfort, and it will also enhance the letdown effect. Breastfeedings, applying cold compresses to the breast can reduce swelling and maintaining the milk supply. The breasts need to be stimulated by a nursing infant, a breast pump, or manual expression of milk. There are various pharmacological and non-pharmacological interventions that would help suppress the lactation and relieve the symptoms. There's no contradictory information right now about suppressing the lactation. And if the woman doesn't want to breastfeed, she can use things like a tight bra, a supportive bra, putting ice on the breast for 15 to 20 minutes every other hour, avoiding any sexual stimulation. Don't manually express the milk from the nipples. Avoid exposing the breast to any type of warmth, including hot showers. And then if they're not breastfeeding, the engorgement will hopefully subside within 2 to 3 days by using those measures. So for the woman not breastfeeding her newborn, which measure would be most appropriate to relieve the engorgement?
Is it C?
Is it D?
I think C, ice. Huh?
So not breastfeeding, okay? If you're not breastfeeding, you wouldn't want to do anything that's going to encourage that milk to come down.
Right.
Why?
Because that's going to stimulate the milk, more milk to come out.
Okay, so we're not going to do anything that's going to stimulate milk. So also, if you look, one of these things is not like the other. One of these things is going to stop the production of milk. Everything else will promote the milk to be produced.
Yes. So I believe it's ice.
Engorgement, you're always looking for things that are going to stop the milk flow or not allow the milk flow to come down, but provide comfort. So that's going to be things like ice, things like over-the-counter analgesics that are safe. That's what you're going to use. Tight bras. These are things that it won't relieve the engorgement, but it'll stop the engorgement from occurring. The ice would relieve it, and the analgesics would relieve it. Okay, the tight bras and the other stuff would stop the milk from coming down to begin with, to hopefully prevent the engorgement from happening. So if we're not breastfeeding, you want ice every 15 to 20 minutes, every other hour. All right, 4 major hormones influential in the postpartum period are estrogen, progesterone, prolactin, and oxytocin. The estrogen is extremely important during pregnancy, but at birth, the levels start to drop extremely, and their lowest peak will be within a week of the postpartum period. The progesterone levels are going to be reestablished with the first menstrual cycle. We already discussed that ovulation may occur before menstruation, so breastfeeding is not a reliable method of contraception unless the mom exclusively breastfeeds. I would still recommend a second form of birth control. All right, psychological changes. So what kind of vulnerability is mom going to have here?
Depression.
What is it?
Depression.
Why?
They have that postpartum blues, like they feel like they I don't know how to say it, but they do a risk, and they are risk for postpartum depression because they feel like they have lost something, and hormones and everything.
What else?
Overwhelmed.
What is it?
Caregiver
They
stress.
can feel overwhelmed.
Okay, overwhelmed. They may not know how to, or may not think they know how to be a parent. So as the nurse,
They may not have the
okay, you
support
can help the
from family.
woman learn. You can help her gain confidence as she transitions into parenthood. It's an exciting time for her to celebrate a new life, but now she's facing different challenges. What kind of challenges is she facing?
Is the other parent, either her spouse is not there, and then the family is not supportive.
Nope, that's not what I'm looking for.
Financial.
We just talked about this. What's happening to the body? She's going to be physically exhausted. Why?
Because
After birth,
She
she's taking
just
care
gave
of
birth.
Okay, she just gave birth. The baby's up feeding all hours of the night.
night.
Her levels are down. She hasn't eaten or drinking any fluids for days. So postpartum depression, and what else are they at risk for? Postpartum what?
Depression, psychotics.
Yes,
I mean,
psychosis. Okay,
psychosis. I'm
good.
sorry.
Okay, so they may actually start to even develop some
Baby's blue.
hallucinations,
Good.
delusions, all kinds of changes can happen there.
The first thing, Miss Sue, is not baby's blue first, and then after that, that's the psychosis.
They may not go to baby blues. They may go right
they
into
may not.
psychosis. It's not a step. Like you don't go from one to the other. They could have one or the other. Now they could go into the baby blues and end up into a psychotic episode.
Okay.
You don't necessarily have to go into the baby blues to become psychotic.
Okay.
They might go right to the psychosis, depending on the woman and how stable she was before she even got pregnant.
Got you. Okay.
All right. So as the nurse, you can help the mom a lot with this. Okay, what kind of self-care measures are we going to teach mom? So after pains, what are those?
Is when they usually feel it while they breastfeed after the baby. Is when the contraction of the uterus.
Okay, so we have this oxytocin being released. The uterus is trying to go back to its pre-pregnancy state, and it's contracting. It's trying to get rid of the dead tissue and all that stuff and go back to its normal state. So after pains are a normal feeling. Okay, what can we do about it?
They could take medication, I guess Tylenol or ibuprofen.
Okay, they could take some sort of mild analgesic to help with the pain.
And you should teach them, just like you said, teach them that it is a normal stage after birth.
Okay. We're going to also, what? Teach them how to do these Kegel exercises.
Okay.
To restore that perineal muscle, right? The pelvic floor muscles, we want those to be restored.
Nutritional.
Make sure that we anticipate their needs, right? For food, fluid, and all that, because what phase are they in here?
The
What phase are they
phase,
in? Right
taking
after
in,
birth, when they need the body.
Taking in.
and phase, taking in.
Okay.
Taking in.
Taking hold phase is when? That's the taking in phase, when it's the taking hold phase.
That's when they're tired, they're taking hold. That's when they start taking care of the baby.
Okay, so they're transitioning. They're still a little bit dependent, right?
Yes.
But they're also now taking on less of a dependent role and going more towards an independent role. Okay, and caring for the baby. And what about the final phase, letting go?
That's when they are able to know that they realize that they have the baby, and then they are able to go back to their friends, I guess, be able to go out, I guess. That's how I always put it.
Into that role of motherhood now. They're accepting the baby as not a fantasy anymore, part of a real lifestyle, right? And now they're taking on the role of the maternal or the mother. Why am I pointing it? Let me in. Okay. All right, so postpartum, let's talk about some of the expectations with the hot and the cold. I wonder if I put those notes on my other slide. Let's see them. All right, so after the baby, there's a couple of things. One, cultural changes, okay? So you have to know what would be the postpartum beliefs, practices, and customs. You want to know that, if you're taking care of somebody who is not from your background, or that you're not knowledgeable about their customs and beliefs, you would want to get to know those. You have to be open, respectful, non-judgmental, okay? Some things that you should know is that the birthing experience is unique for each woman. All right, so Somali women, they're highly regarded in their roles as mothers. Those women would stay at home and refrain from sexual activity for 40 days. And then at the end of that 40 days, they would have a celebration for the mom and the baby. Majority of Somali and Arab women will breastfeed for extended periods of time. Nurses also have to offer early breastfeeding instruction for these women before discharge. Other things we talk about are hot and cold. So a lot of cultures believe that good health is the balance of hot and cold substances. And with the blood loss, they consider that to be hot. The postpartum period is considered to be cold. So the mom has to balance that with the intake of hot foods. So during the postpartum period, they would want the mom to eat a lot of these hot foods because it's considered cold in the postpartum period. So the hot foods would offset the balance of that cold. So during this time, some cultures would want mom to refrain from eating things like fruits and vegetables. Western practices would incorporate using cold packs or sitz baths to reduce the perineal swelling and discomfort, but they would not be acceptable to certain cultures, such as, but I don't list them in your book, the ones that they're not acceptable to, but the ones that they are acceptable to are Latin American and Asian. So Latin American and Asian is where you're going to see most of those hot and cold beliefs used. All right, engrossment, visual awareness, tactile awareness of the newborn, perception of the newborn, attraction, awareness of distinct features, extreme elation by the father, and increased sense of self-esteem. So engrossment itself is characterized by several different factors, okay? 7 to be exact, 7 different behaviors, all right? So one of them, the first one being visual awareness. This is where the partner or the spouse receives the newborn or perceives the newborn as being beautiful. The tactile awareness is where the significant other has a desire to touch and hold the newborn and finds that to be pleasurable. The perception is where the partner does not see any imperfections on the newborn. So remember, you might not see some of these things occur if what happens to the baby.
Can you repeat that, Miss Sue?
So we're talking about the visual awareness where we see the baby as being beautiful. The tactile awareness where we want to touch and hold the baby and we consider it to be a pleasure. This is our partner now. We've given birth.
Yes.
So now our partner's in the room and our partner looks at the baby and finds the baby to be beautiful. They touch the baby and they find that to be pleasurable. They see the baby or they perceive the baby as being non-fallible or with no imperfections. When would we not see this occur?
Is it when the child is born preemie or at home, when they are at home?
So I would say more likely when the child is born with something like a cleft palate or some abnormality that makes the child not appear normal.
No, like not to be
Child is born with a cleft palate or something like that, or the parent's going to see them as beautiful.
Oh.
Are they?
No,
No,
if they have a cleft,
no.
that's
Let's just talk
that's an
realistically, okay? Let's just talk realistically for a minute. Some babies, even though they don't have a cleft palate or any disability going on that's visible, are they still beautiful at birth?
No,
No, babies are ugly when they're born.
not all of them.
Molded and just shaped and everything like that. I mean, people really lie to people, right? Oh, your baby's so cute. And in your mind, you're thinking, damn, that's an ugly baby. But you don't want to say that to the mom. But you know that we all think that. It's true, right? Not all babies are beautiful when they're born.
You're correct.
But we're more likely to accept that baby if it doesn't have any disabilities, right?
Yeah.
When it has facial disabilities, stuff that we can visibly see, you're going to have a hard time even looking at the baby sometimes if you're the parent, especially if it's a baby girl. Not that you don't want your boys to be handsome, but, you know, girls and their face, there's a little bit of something to be said about that, right? Nobody wants a girl with a scar on their face or with, you know, things on the face that don't give it beauty. And so if I don't see the baby as being beautiful, and when I touch the baby, I don't feel like the baby is beautiful or without perfection, how am I going to feel when it's time for me to bond or, you know, to be part of that baby? Am I still going to be as comfortable with it? And the answer is probably no. So you're going to have to think about that part when the baby is born with some sort of issue there.
Miss Sue, I'm sorry, but in the eye of a mom, I don't think they ever see their child imperfect. In the eye of a man, maybe, but a mom will, even though the child is butt ugly, I think the mom will still find something in a child to say that my child is beautiful.
Everybody agree with that?
No.
No,
Because they have some moms out there.
I agree.
They have some moms out there that
Oh,
have some pretty distorted thinking.
oh my God. As a, you know, okay, to each his own, I'm sorry, but I feel like after you push the child, you count the finger and the toe, and you're like, oh, she's beautiful. Even though you tired, you'll still say something and then go to the second stage that, oh my God, I'm tired. But you still will say in your mind, in your heart, that's mine. I mean, okay, I guess it's not every woman.
What if I didn't want the child? What if I didn't want the child? Maybe my dad raped me. Maybe my brother raped me. Maybe
but that's something different,
or
Miss
maybe
Sue.
I just don't want the child.
Miss Sue, that's something totally different. Even when a woman is going to give their child for adoption, they start second guessing themselves. That's okay. I guess that's okay.
I disagree that all women have that motherly instinct. I disagree with that.
Okay.
Because there are women out there who allow children, okay, to be molested. They allow people to do things to their children. They do stuff to other people.
That's true.
Okay, so if there are women out there like that, that means not every woman has those maternal instincts. Some women eat their young. I'm just going to let you know that. Okay, yes, normally, you know, listen, if I'm a mom and my kid's in prison for murder, normally I'm going to say, no, that's not my child. I love my child. My child would never do that. And that's, as a mom, that's the way I'm going to think about them, because I can't see the bad about my child. That normally happens with the mom, but not every mom is in that phase. And so that's why you have to be aware of what's going on. You have to watch that interaction between mom and the baby, because you could send that baby home with a monster.
Mm-hmm.
Okay, there are monster women out there, just like there are monster men, and they'll do the same discreditable things to that child that a man will do. It's not just men. And that is what I want you to see. You know, back in the day when, you know, when I grew up, you didn't think about women cheating on relationships and all that stuff because it really wasn't if it happened, people didn't know that it happened. But now it's a different world. Women want to be equal to men. So what you see is, which I don't understand why, because women are already stronger than a man, okay? If you try to make yourself equal to a man, to me, you're taking yourself down, not up. We're already stronger than a man. We already have all these things going for us. So when you start trying to equate yourself to a man, oh, if he can cheat, I can cheat. You know, if he can do these things, I can do these things. You're not making yourself equal. But this is what women are doing now. And so, you know, a lot of these guys are taking better care of these children than the women are. Some of these women are trifling. They're just baby deliverers. They give birth.
Oh,
They're not raising that child. Their mom's raising that child, or somebody else's mom is raising that child. So we have to start looking at it that way, because that's what's happening. We have to give equal credit to men and women now, because some men are doing this job. But it's definitely possible for a mom to look at her baby and not like that child. Ask Norman Bates. All right, so we were talking about the visual awareness, the tactile awareness, these 7 behaviors that are associated with this engrossment, okay? The perception of the newborn is perfect, the strong attachment. So the focus from the partner would be a strong attachment from that newborn as well. Awareness of the distinct features. So, you know, the partner can look at the baby and determine that's my baby, not somebody else's baby. And then elation. So the partner feels some sort of high after the baby's born. And then the partner feels proud about the baby and proud about the birth. So sometimes our significant others are expressed as, you know, they fumble around a little bit when they try to take care of the baby. All right, but remember that they have their own unique way of relating to the newborn. All right, and they can become nurturing. It may not be the same way mom does it. Mom's got her own thing going on. And it might not be as automatic or as strong as an attachment. What you'll generally see when you have normal family dynamics is usually dad will take more of a bond to the baby girl, and mom will take more of a bond to the baby boy. Not always, but the majority of the time, that's kind of what you see. And that's not in your book, but if you look around in real life, daddies are usually more attached to the daughter and mom's usually more attached to the son. We want to encourage, okay, the significant other to touch, hold, cuddle a baby, to do these other things to try to encourage that attachment or that bondment. And by doing that, we reinforce the engrossment or that engrossing behavior, right? So 7 things there. All right, and then we have the 3-stage role development process. Okay, so similar to the mom, the dad or the partner will also go through this 3-stage process during the first 3 weeks as they start to develop their own role. So stage 1, they have these expectations about what life is going to be like with a new baby. Probably wrong. All right. They're not really aware of what kind of dramatic changes are going to occur when the baby comes home. So for some, it's an eye-opening experience. So what kind of changes are we going to see in that new family that, you know, dad may not be expecting, or the significant other may not be expecting?
the baby crying all the time.
Okay.
And not being able to sleep at night. Sometimes the wife cannot cook.
So a good point right there. Before it was just him and the wife. And if they're in the kind of relationship where she does a lot of things for him, like gets his clothes ready, makes his food, has his dinner ready, or a little fun time at night, all that's going to change. She's going to be too tired for all that little fun time at night. And if she's taking care of the baby, she may not be able to do some of those other things also. That may anger him a little bit, or the partner. Stage 2 happens when daddy or the significant other now realizes that, wait a minute, this isn't what I paid my dues to get into. And they're now realizing that what they expected is totally different from what they're getting. All right, so now instead of being elated or high on this, I got a new baby trip, they're now like, really? This baby's interfering with all my fun. I can't get a decent meal in this house anymore. And now I'm washing my own clothes and I'm getting up with the baby in the middle of the night. What? This woman who does nothing all day is in the bed sleeping.
Is that the stage that they leave the woman?
Not if they're smart, because now there's child support to pay. But they may become sad. They may have feelings where they like it one day and don't like it the next. We call that ambivalence. They may become jealous of the baby and frustrated. And they may start to be a little mean. And that can start to turn into depression, okay? And that could be for the mom or the dad, because mom could be depressed because she doesn't feel like the partner is now giving her full support, right? And dad can be depressed because he's like, what? This is what I got myself into? And so now, yes, he might start stepping out, and so might she. Unfortunately, men, don't really express their feelings well. They don't know how to talk and communicate. And then a woman in this state of mind might not be exactly who you want to communicate with. Because remember, with those hormonal changes, her emotional liability is going to be all over the place. Are you pregnant?
I need the 2 makeup forms.
Where'd I have them?
How old are you?
Huh? 59.
You don't look it.
Thank you. Because they were talking about a 60th birthday party. I'm like, that's not until next year.
Wow, you
I
look
just
it.
keep pushing the gray out.
That's what it is?
Yeah.
All right, let me make up.
Those are yours. You can keep them. All right. So now, we got both people are stressing out. Okay. The poor baby is stuck in the middle somewhere. Mom's trying to get dad to kick in and help around the house. And dad's like, you stop doing some of your chores now that this little brat is here. So, it can cause some of the, emotions in the house to rise up. And remember that mom is going to be all over the place because of those hormones. All right. So for mom, postpartum depression, okay, is going to be based on risk factors. So most of those risk factors are going to be a previous history of depression, financial problems, poor relationship. So it could be for mom or dad here, okay? Poor relationship with mom or poor relationship with dad, having the baby during the when it's unplanned. Nobody planned it, right? They're like, oh, we don't know how the baby got here. All right. Well, you had sex, you didn't protect yourself. So, but you don't know how the baby got here. And then when they start to present with these signs of depression, they're going to seem like they have a lot of stress. You're going to see anxiety. You'll see them being discouraged. They may show signs of resentment from the infant and the attention. This is mostly about the partners. All right. And then they may experience symptoms. So you want to make them understand that, you know, this can be a normal process of the birthing process. So they should probably get help, seek help from somebody. Stage 3. Now the partner makes a conscious decision to take control and be part of the newborn's life, regardless of the fact of whether they're prepared or not. Okay, and this is similar to mom's letting go phase. So now they step up to the plate, all right, and they welcome the new family member and they start to take care of it. And that's the transition to mastery. So expectations, baby comes home. We get these expectations that we didn't expect. This is daddy or the spouse. All right, reality starts to set in. I'm angry because of the attention and stuff that the baby gets, and I might develop some postpartum depression just like mom. If that happens, if I see this discouragement, if I see these feelings of resentment, if I see that dad is not transitioning to that role, and I probably would see this more as the home health nurse that comes in to do the evaluation once mom and the baby go home. You might see it while the baby's still in the hospital, but not likely because the baby's only going to be there for a couple of days. And remember, this doesn't start to happen until 1 to 2 weeks after the baby's born. The baby comes home and they realize that it's not the fairy tale they believed in. All right. And then if they get past that stage, they get over that depression, they get over that anger, then they can transition into that mastery stage, welcome the baby. If they don't, then they may have to seek additional treatment. All right. What would put them at risk for that would be having a poor relationship with the mom, having financial problems, those kind of things. All right, attachment during this phase. Okay, mom is forming the attachment with the baby. Dad is bonding with the baby. And we have this closeness of the family unit. Okay, and for maternal attachment, this is where mom is bonding. Okay, she's building strength, she's building power. It starts before birth. It will also occur during the prenatal period, and then also after the baby is born. As the baby grows, the parents will start to learn what the baby's cues are. They'll start to adapt to the baby's behavior, and they'll start to meet the baby's needs. Now, during the early postpartum period, things that can affect the attachment and bonding process may occur. So oxytocin is part of the bonding because it has effects that can enhance the skin-to-skin contact, breastfeeding, eye contact, socialization, maternal and milk odors, which help soothe the newborn. And then newborn massage during the first postpartum hour. You as the nurse are going to assist in the attachment process by promoting parent-newborn interactions, skin-to-skin contact, placing the infant in a kangaroo position, as we call it, by putting the infant on the bare chest of the mom or the dad, okay, to enhance that parent-newborn attachment. You see this being used a lot in the NICUs right now. And they're doing it with both parents because it helps these babies to improve significantly when they're in the NICU, especially like these preemies. Another way that you can help mom to attach with the baby is to encourage breastfeeding. All right, and then also nurturing activities like touching, talking, singing, changing diapers, feeding the baby, these kind of things will also promote attachment. The attachment is a complex and influencing factor for the baby. It involves the environmental factors, the health of the newborn, and the quality of nursing care provided. And you definitely want to promote, okay, these interactions by promoting that kangaroo care, the breastfeeding, and mom and dad's participation in the newborn care. It will also provide positive psychosocial support to the parents and help them with that attachment process. All right, so for most people, childbirth is a time of happiness, but some women can experience changes in their mood, and they may feel fatigued, irritable, or worried. Sometimes they become severe enough to require intervention. Perinatal mood disorders are a common complication and usually occur during the postpartum period, impairing the mom's ability to provide care to the child. In the postpartum period, mood disorders are divided into 3 distinct entities. The first one being maternal baby blues, postpartum depression, and psychosis. But they have not been divided as either a distinct disorder or a single disorder or one that occurs in a continuum, meaning coming back to back. So about 85% of new moms will have those baby blues or maternal blues. Now, baby blues or maternal blues are characterized by mild depressive symptoms, anxiety, irritability, mood swings, loss of appetite, tearfulness for no reason, increased sensitivity, and fatigue. They usually start on postpartum days 4 and 5, and they can last from hours to days, and they're usually done by day 10. The symptoms can be distressing, but they don't always reflect that mom is in a psychotic episode or the mom's ability for her to care for the baby. And then with postpartum depression and psychosis, the symptoms are going to last longer than that. They'll be more severe and they could require additional treatment. It also could cause poor bonding for the mom. It could cause the mom to be alienated from the baby and other people. It could cause dysfunction in activities of daily living, and it could cause the mom to become violent towards someone else or towards the baby. So you definitely want to pay close attention to that. In order for the mom to take an active role in the baby, there are some things that may affect that. Okay, and those kind of things would be her confidence, her age, what sort of relationship she has with the baby's father or with the person that she's birthing with. It might not be the father, it might be somebody else. Socioeconomic status, previous birth experiences, how much other stress she has in her life, her current support systems, her personality traits. Basically, it's going to be the normal ones before she got pregnant. Her attitudes about raising the child, any other kind of strain that might be on the relationship, like finances, the mom's overall health status, how well that the parents prepared, not only before, but during the pregnancy, their relationship with their own mother, and did their own mother have depression, anxiety, the baby's appearance, the baby's responsiveness, the baby's temperament, and the baby's health status. Because if the baby's not healthy, or if the baby is crying all the time, if there's causing more factors there causing disruption in the household, then it's going to contribute additionally to this. And the 4 stages of becoming a mother are commitment, attachment to the unborn baby, preparing for delivery and motherhood. During the acquaintance and attachment stage, the mom learns how to care for the baby, and remember that physically her body is still being restored. She's moving towards a new normal, and she's trying to identify herself as a mom. Okay, and she's looking at the different sort of behaviors and stuff that she has to start to now incorporate as a mom. So commitment, preparation for pregnancy, learning to care for that infant, and physical restoration during the first 2 to 6 weeks, moving towards that new normal, and then achievement, feeling self-confident, feeling confident in her ability to mother and express love for that child, and being able to interact for that child. Questions on that? All right, let's see how much we can get to this other chapter. Chapter 16 is nursing management. I'm trying to get these slides beefed up so I can send them to you guys. I'm working on it. Another chapter that I'm probably going to go over, and I'm going to try to have another meeting with you guys before next Saturday. So when can most of you get together? I don't have time really to do one-to-one tutoring with anybody right now. So if you guys have another date and time when we can get together, then I could try to go again, not just through chapter 16, but I really want to go through chapter 22 with you guys. Because that's about bleeding and all that stuff, and complications that are happening after pregnancy.
I'm okay, whatever they say, I can figure out the timing. I can do the adjustments.
How about Friday? We don't have school on Fridays.
Fridays doesn't work for me because that's my only day off and I have to have it. And actually these Fridays right now, I've actually given up my vacation days on Friday because we don't have a day psych teacher, so I'm teaching psych on Fridays.
Oh,
How about tomorrow?
Yeah, can we do some peas tomorrow? Because we had the peas test Tuesday.
yeah.
I mean, I don't have a problem doing peds with you guys tomorrow, but you know, the reason why I'm really working on the OB is because that's where it seems like mostly everybody's struggling.
Yeah, that's true. Obviously, yeah.
But I mean, we can do a peds session in the morning. My 8 o'clock person isn't showing up routinely, so I can do an 8 a.m. session tomorrow on peds. If my 10 o'clock person doesn't show up, then we can maybe go to 11 and I could try to cover this other chapter. I really want to go through this chapter 22 with you guys on OB because I think that these two chapters are going to be your most important. One is talking about the physiological changes after birth, and the other one is talking about postpartum complications and how you're going to address them. So tell me, for peds, what do you guys want to cover tomorrow?
Well, isn't the chapters for peds tests is what is it, like 37,
Neuro.
38, and
Yeah,
huh?
Yeah, we probably need neuro. It's neuro,
And skin.
and
Skin.
infection.
Oh,
Those are the three
infection.
ones. That's what yeah. So I know neuro is a big one, and the skin too.
Neuro and infections.
And skin.
And the skin, and the skin. So whatever you can help out with it, especially neuro. I know that's probably like the hardest one. I don't know if everybody would agree with it, but
All right, since we're not really going to get through the other chapters, let's just go through a few questions. Because as soon as I get started on this, people are going to start jumping in for the next session. We only got like 10 minutes. So I just want to go through some postpartum questions with you guys and see how you do.
Yeah.
you doing, Saunders? Well, I don't want that book anyway. So how about that? Let's go back here because this is the wrong book. That's the PM book. We want the RN book. Let me know when you can see it.
No. Yes.
Okay, I'll read the question. You guys are going to read the answer choices. All right. A rubella titer result of a 1-day postpartum client is less than 1 to 8, and a rubella virus vaccine is prescribed to be administered before discharge. The nurse provides which information to the client about the vaccine? Select all that apply.
B.
Number 2, pregnancy need to be avoided for 1 to 3 months.
Okay.
The vaccine is administered by subcutaneous route.
Okay.
Number 3,
Or-
or number 4,
4.
exposure. I think that's it.
It's a
I
live
don't-
virus, right?
Yes,
It's
it's
a
a
Yes,
live
live virus.
virus.
So I think it's 2, 3, 4 in my view. I don't know.
Yeah, that's what I see.
Anybody else think anything else should be up there?
1, 2, 3, 4, 5.
And I believe neomycin for this one, but I'm not 100% certain on it. All right, rubella vaccine is administered to women who have not had rubella or women not serologically immune. Vaccine should be administered immediate postpartum to prevent the possibility of contracting rubella in future pregnancies. The live vaccine is not communicable in breast milk. Breastfeeding does not need to be stopped. The client is counseled not to become pregnant for 1 to 3 months because it could cause damage to the live fetus. All right, the client should use effective birth control. The client should avoid contact with immunosuppressed individuals because of their low immunity with live viruses and because the virus is shed in the urine and other body fluids. The vaccine is administered by sub-Q route. Hypersensitivity reaction can occur if the client has an allergy to eggs because the vaccine is made from duck eggs. All right, everything
Oh.
else was not
I didn't know.
applicable.
I didn't
made
know
from
that for the
eggs.
rubella.
The nurse is providing instructions to a pregnant client with HIV regarding care to the newborn after delivery. The client asked the nurse about feeding options that are available. Which response should the nurse make to the client?
A.
Yeah, it's A.
You cannot breastfeed.
No.
So just so you know, A is the correct answer. However, they are doing studies right now and they are showing that it can possibly be safe to breastfeed these infants. Right now, according to your author, it's a no. Okay, because right now they don't have enough evidence to show that transmission can't occur. Once they can prove that or that the antibodies are good for the infants, then they may go to this method. All right, good. A stillborn baby was delivered in the birthing suite a few hours ago. After delivery, the family remained together, holding and touching the baby. Which statement by the nurse would assist the family in the period of grief?
A.
1,
Yeah.
Okay,
A.
good. You guys don't need that rationale. we're gonna skip these grieving questions. The nurse evaluates the ability of a hepatitis B positive mother to provide safe bottle feeding to her newborn during postpartum hospitalization. Which maternal action best exemplifies the mother's knowledge of potential disease transmission to the newborn?
Is it 4, Miss Sue? I don't know.
Yeah, it looks like it's 4.
Yeah, it looked like the hand wash and something like that.
Okay,
Is the
well,
other-
let's look at the other ones. So if you don't know the answer to this, the other ones pretty much seal the deal for you, I would hope.
Mhm.
Right? Because it's not gonna have anything to do with spreading it. All right.
Yeah.
Neither is the way she holds the baby. And the temperature of the formula should be tested, but it wouldn't prevent the spread of anything. Okay, except maybe botulism.
Yeah.
Okay, good
Alright.
job. All right, so Hep B is highly contagious, transmitted by direct contact with blood and body fluids of infected people. The rationale for identifying childbearing clients with this disease is to provide adequate protection of the fetus and the newborn to minimize transmission. The correct option provides the best evaluation of the understanding of the disease transmission. Option 1 will not affect disease transmission since Hep B does not spread through airborne. 2 and 3 are appropriate techniques, but do not minimize transmission. Client is diagnosed with placenta previa. The nurse plans care with the understanding that which is associated with placenta previa.
Is it A?
A, 1.
Is it 1?
Mhm.
The placenta is implanted in the lower segment of the uterus.
Yes.
So you should have been able to get to that through the process of elimination, right?
Yes.
Mhm.
Okay, good. In placenta previa, one placenta is normal size, implanted in the lower uterine. The segment does not contain the same musculature as the fundus of the uterus. So the greatest risk with this is bleeding. And if mom starts to bleed, then what do we have to worry about?
Hemorrhage.
Hemorrhage and fetal demise.
So hemorrhage is the bleeding. What do we have to worry about? if
Oh,
there's
the fetus.
Fetal heart and fetal demise.
bleeding? And what's going to happen if she bleeds?
Hypotension and
Hypotension.
DIC.
Okay, she's going to go into shock, which is
Shock.
hypotension is part of that. So you have to think about that because you have to think about how am I going to treat? All right, you're going to treat her similar to a nature you would treat someone in shock. So you're going to prepare for things like blood transfusion, prepare to give fluids, prepare to possibly deliver this baby, depending on when the mom is, how far along. Now, usually this and abruptioplasia usually happen later in the birthing process. So they usually happen in the later trimesters. The postpartum nurse is taking vital signs of a client who delivered a healthy newborn 4 hours ago. The nurse notes the client's temperature is 100.2. What is the priority nursing action?
notify the promoter.
100.2. Oh,
I would
Notify the
is it
primary.
take it.
Retake it.
Retake
15
it.
minutes.
What is it?
and 4
Three.
hours.
Okay,
Oh.
so let's go with 1.
3.
Okay, we are probably going to document the findings, but it's not our priority, right? We're not going to retake. We don't recheck vital signs, temperatures, and stuff like that usually. And if there was a problem with our client, not with the temperature necessarily, but with some things, in 15 minutes, they could be dead. All right, so you're not going on break and coming back and rechecking. So now you're down between 3 and 4. So what you have to determine is this something I would expect to see?
No.
Increase.
Why?
Yes, because you said that the first few hours, the temperature of the after labor, the temperature could go high. Yes.
Why?
4 hours though.
Because
Why?
of the instability in the temperature, instability in the in the pregnancy, I guess, the placenta.
Okay. What happens during pregnancy with our fluids?
It
We
dropped.
lose his fluids.
Drops, right? And
It
what
dropped.
does it help control in the body?
Oh, fluid is temperature. Fluid
Right.
is
Yeah.
yes.
It's a mild change here, and it's within 4 hours.
Yes, so I will not call the doctor. I will increase their hydration, I guess.
Yes, we can increase the hydration, then call the maybe doctor.
You're not going to call the doctor if it's a normal finding,
Most,
Oh.
yeah.
because the doctor's going to yell at you. So you're not calling him, okay? Now, if the temperature don't come down, it continues to increase, there's another problem, then you are. But first,
Well, if
the hydration status back to normal. Remember, she just lost a lot of fluid. And so that's why you have to know those changes we just went over, because that's going to dictate what you're going to do on these priority questions.
But Miss Sue, if the temperature is continuously rising and the blood pressure is dropping, then you call the doctor then.
Well, then you're building more into the scenario,
Okay.
right? You can't build more into the scenario. You've got to deal with what you have on hand. So you have to first determine, is this normal? First of all, it's 4 hours after the baby's born. So unless there's some other risk factor, how long does it take for an infection to develop?
Flowers.
Within minutes.
Minutes.
3 to 5 days, not minutes.
What?
You should know that from med surge. 3 to 5 days for an infection to develop. All right.
Miss Sue, okay. In the book it says that a woman could develop infection when they check check them too much because of the how long they are in labor, and because so many people are checking them, they could have infection. So disregard that.
No, they could develop an infection. But if I'm checking you today, how long is it going to be before that infection starts to present?
Okay.
It takes time to grow. That bacteria has to grow in the body. And that's why they're saying a lot of times after the baby's born, it's hard for them to determine if there's even an infection present. Why? What's going to happen with the white blood cell count?
Going to increase.
It's going to be increased after pregnancy. And it's not going to return to its normal of 6 to 10,000 for a few days. Now, if let's say mom came in on Thursday and her water broke, but she didn't have the baby until Saturday. And Sunday, when you come in to see mom, her temperature is elevated and it's above, you've already done the fluids and all that, and it's not coming down. So now you're starting to think she has some sort of infection. But that infection didn't start yesterday when she had the baby. It started 3 days ago when that water broke. So she might develop that infection while she's in the hospital, okay? And it may appear right after she has the baby. But the infection really started developing a couple of days ago. It didn't develop that day and all of a sudden become prominent. That's what I'm trying to make you understand. All right, so infections take 3 to 5 days to develop in anybody for anything. And that's why if my patient was going into surgery and they had an abnormal UA, I would want to notify the doctor of that because they're already in a possible state of infection now. So that's what you have to look at. If they have an infection, that means that infection developed a couple of days ago. All right, or it started to develop a couple of days ago. It's just now starting to present itself in the body where I, as the nurse, can recognize it, because now it's causing my temperature to go up. Now it's causing my white blood cell to go up, and it's causing me to feel horrible. All right, so most diseases, most infections, you're going to have a few period of days there where you're starting to feel a little lousy, but you're not quite there yet. So temperatures in the first few hours, okay, the first 24 hours actually are generally related to dehydration. Do I have people on here for math? Well, I don't, so we can stay on if you guys want. Because nobody's answering. Okay, so all right, so the nurse is assessing a client who was 6 hours postpartum after delivering a full-term healthy newborn. The client complains to the nurse of feelings of faintness and dizziness. Which action is most appropriate?
Instruct the client to request help when getting out of bed.
Okay. Anybody else think of anything else there?
Just a minute.
Yeah, safety. We'll go with 3.
Why wouldn't we worry about 2?
It's 6 hours. Postpartum. Healthy. She have a healthy.
If
Why would I want to check her hemoglobin and hematocrit when she had a healthy full-term baby, but she only complaining of fitness and dizziness?
Okay, and we know that usually the hemoglobin and hematocrit remain what after pregnancy?
Stable.
Okay.
It will stay the same.
Okay, why wouldn't we raise the head of the bed?
because she's not
Because
having
she's not
trouble breathing.
Breathing.
It's not
She
going to
don't
help
have
her.
no-
It's not
no
going to resolve the issue, right?
Yeah.
Okay. And 4 is not going to help her. All right.
No.
Sure, we're really looking at all the options and ruling them out, not just trying to pick the best answer, because you need to do this when you get in the exam.
Yes, ma'am.
The postpartum nurse is providing instructions to the client after the birth of a healthy newborn. Which time frame should the nurse relay to the client regarding return of the bowel function? Now, we just talked about this, right?
7 days, I think. Not
You think
3
someone
days.
should be without bowel function for 7 days?
Oh,
It's a long time.
Yeah, but don't they?
It is like 3 days.
That's the reason why that they give them. Okay. Don't
Yeah,
they give
3
them so?
days is really more appropriate.
Yeah,
It's not
3
going to
days.
be on the day of birth because of the anesthesia, the surgery, and all that is going to slow it down. But by day 3, we should start to see some flatulence, some bowel sounds starting to return. 7
Okay.
days, 2 weeks is too long.
Okay.
And I just gave you the rationale, so we're going to go on. The nurse is planning care for a postpartum client who had a vaginal delivery 2 hours ago. The client required an episiotomy, has several hemorrhoids. What is the priority nursing consideration?
Send me over 1,000.
Pain.
Pain.
pain level. Yep.
Okay. Why not 4?
Potential for invalid body fluid volume.
Because there's mentions nothing about that in the question is asking about because she had the episiotomy and
And hemorrhoids.
And the hemorrhoids.
Okay, why
That's
not
really-
3?
Because
Adi,
it
they
That
know
would
has
that.
be
nothing
the-
to do with GU, right? Like it's
That's not our
Does
priority.
have something to do with it. She has this big slice around her private part.
But that's not
However,
a
if we're going
priority.
by Maslow's hierarchy, would 3 be our next issue?
No, it's not a priority.
That's not a
priority.
priority. Yeah.
All right, what about 2?
It doesn't say that
It
her
doesn't say
urine
that
out.
she has a problem urinating.
Okay, doesn't indicate there's an issue, and we would expect what to be going on here?
She will have a more urine output. I think the bladder will.
Diuresis, right? That bladder's going to fill up with urine. We would expect her to be diuresing here.
Yeah.
All right, 1 is a problem. Why?
because hemorrhoid is painful, and she just had the episiotomy, which is like also
Very painful. Okay, and she's sore. She might be scared to poop. All right, a lot of things going on there. All right, good. All right, so priority is pain. All right. And nothing in the question that indicated the inadequate urinary output, but I wanted to talk to you guys about that stuff so you remember that in this stage, typically, not that we wouldn't have inadequate, because we could. Why would we have retention of urine during this stage?
Because they could have had just a catheter take it out. Maybe. No, I don't know.
Remember, because of the anesthesia,
yeah.
the swelling, the
But
surgical
everybody did it for
procedure
the seizure, though.
itself, all could cause urinary retention. So we're
Mhm.
constantly monitoring the client, especially if they have less than 150 mLs of urine output. We're looking for bladder distension, because bladder distension could do what?
Can lead to hemorrhage. I mean, uterus, shift the uterus.
Shift or displace the
The
uterus
uterus,
and
yeah.
cause it not to
Hemorrhage.
contract properly. That would lead to uterine atony and hemorrhage.
Mhm.
You guys got to remember this stuff, because if you don't, you're not going to do well. You want to remember this. This is the stuff you really need to know for the exam. This is the meat and the potatoes. The nurse is providing postpartum instructions to a client who will be breastfeeding her newborn. The nurse determines that the client has understood the instructions if she makes which statement?
One, it should be petted and supportive.
2,
So definitely, yeah, she cannot have alcohol.
3,
Use of caffeine also is gonna all start by estrogen, birth control again as soon as it. No, I know if my breast gets. I plan on having bottled water available. So I can. Yes, 6.
6.
She has to increase her
6.
fluids.
Okay, if 5 happens, what are we going to do?
The warm compressions.
What are we going to do?
Can you see?
We
If
have
her
to.
breast become engorged, teach her ways to express the milk.
Yes, because she's breastfeeding. So we're not doing
Oh,
ice. We're
she's
not doing a
breastfeeding, okay.
binding bra. We're doing other things like warmth, heat, stuff to get that milk out, right?
Yeah.
If
Or you
she's
can
not
pump it out.
breastfeeding, then we go with the binders. Then we
And
go
the
with the
ice.
ice. Okay. And then analgesics for both women if they're safe for breastfeeding. And for the other one, you know, usually over the counter stuff. I don't know about 4 here with the estrogen. I'd be a little concerned because of hypercoagulability. So she might have to switch to a different birth control pill, but I don't know because this is not my area of expertise. But I know estrogen causes hypercoagulability. So that would be my concern here. So oral contraceptives with estrogen, not recommended for breastfeeding moms. All right, so that one is wrong because of that. All right, nurse is teaching a postpartum client about breastfeeding. Which instructions should the nurse include? Again, go through them and tell me which ones are wrong and why.
Diet should include additional fluids. Yes. Prenatal vitamin should be discontinued. No.
Mm-hmm.
And soap should be used to cleanse. No. We
The
shouldn't.
answer is 1.
Birth control measures.
Or
No. Well, yeah,
control
it's between-
measures are unnecessary while breastfeeding. That's can still get pregnant, right?
Well,
So
one, I
remember,
will say that,
ovulation occurs before the menstrual cycle sometimes. So we
Yes.
should always encourage birth control. There are a couple times when they say it's unnecessary, and this is according to your author. If the mom's baby is under 6 months old and breastfeeding is her primary method of feeding, she can't use any bottles or anything else. I still would recommend birth control. Why not soap?
you don't use soap when you cleaning your breast.
Why?
You just,
Why?
because
To
of the
dry it out?
toxin that is in the soap could get into the breast if it has mastitis. So you don't
Well,
want
what
it
if you
to.
don't have mastitis?
Well, you just don't. I know. Clean
Why?
water.
Why, nurse? Why can't I use soap? I need soap.
Because it's gonna dry.
Why
Dry up.
It
Yeah.
dry
Yeah,
your skin.
It's
out.
gonna dry
It
out.
dries. Yes.
It
Correct.
removes
Thank
the
you.
natural oils from the skin and causes the breast to crack.
Crack. Okay.
Don't give me generic answers. I'm not taking them.
Yes, ma'am.
Prenatal vitamins, why should they not be discontinued?
You have to take it while they're breastfeeding.
Because of the iron that is in the prenatal.
Okay, because mom still needs some of this stuff in the body after the fact because she might not still be taking it in adequately by mouth, right?
Yes,
Mhm.
ma'am.
All right. And
Well-
extra fluids, why?
Because in your diet, because breastfeeding, you removing, the child is taking fluid out of you. They always ask you to add fluid so that the mom does not get dehydrated. That's my say.
Okay, it's also going to help,
Also
those
increase the production of milk.
clogging, right?
Hmm?
It's also going to help those breast ducts from clogging.
Oh, okay.
So I might have people chiming in here for math. I don't know. Or is this still, it doesn't look like it. It looks like it's all you guys. Okay, good. All right, nurses preparing to assess the uterine fundus of a client in the immediate postpartum period. After locating the fundus, the nurse notes that the fundus feels soft and boggy. What intervention is appropriate?
Well, elevating the legs is for DVT. So they're
Massage
not saying
the
that.
fundus. I think massage the fundus until
Massaging the fundus until it's firm. That
It's for hemorrhage.
is because of the clot or hemorrhage. And you want it to massage it so that any particle that is inside could come out
Why?
It's
because of hemorrhage. And you don't want those little particles to stay inside after the
Why
birth,
will it
because
hemorrhage?
I think it's 2.
Why would it hemorrhage if those particles are inside?
well, you massage the fundus for it to come out and for the uterus to start getting firm, because you don't want it to be soft and buggy.
Why can't I just push on the uterus and push the clots out and get rid of the stuff?
Or that's part of it. That's what you're doing.
No, we cannot. That's gonna be a risk for hemorrhage if we are pushing. That's even worse. We have to massage the fundus
You
to.
Until
massage
it
the
gets
fundus.
firm.
So what's the purpose of massaging the fundus? Why do I need to push all those little parts out?
Because it can cause a hemorrhage.
Why?
If those little particles stays in, the mom is at risk of an infection because you don't want those little particles that stays in stays in.
Okay.
The fundus not supposed to be for the.
Why?
fundus-
Because
the
the
fundus-
uterus cannot contract fully.
Properly, yeah.
When we have bits and pieces of tissue from the placenta or blood that are left inside the uterus, we probably won't see it right away. A couple of weeks after mom goes home, the uterus is not fully contracting. Mom's going to develop subinvolution of that uterus and probably start to hemorrhage. So that's why we have to make sure that we get all those little components of the placenta out. And then when that uterus becomes boggy, we're going to massage it and try to make it firm again. That is the correct answer. Elevating the client's legs, I'm not sure about for the DVT, but typically when we're elevating somebody's legs, especially if we're lowering the head, we're trying to stabilize the pressure. For 3, we're usually doing this if a patient is in recovery, at risk for aspiration, or they need more oxygenation for some reason. And 4, we're not doing because it could precipitate the mom for complications like a hemorrhage. Okay, so we need it to contract all the way. All right, that's what's going to help the client in this case. You guys had the right answer. I just want to make sure you fully comprehend it, because if you don't comprehend it, then it's going to be harder when you try to do questions. All right, nurses caring for a 4 one-day postpartum clients. Which client assessment requires a need for follow-up? So here you have to determine what is most abnormal, or what is abnormal and what's not.
4.
Yeah, 4 is it shouldn't be foul smelling.
Okay, what about 1?
4.
What about 1?
I mean,
Some people
That's
have mouth
mouth
expected.
pain
Yeah.
is normal, right?
Normal. Okay, what
Birth.
about 2?
That's all right.
It's normal.
What do we expect the pulse to be right after the baby's delivered?
40 to 60, I think.
Okay, it's going to be a little bradycardic. If it's tachycardic or over 100, what are we looking
When we
for?
get concerned.
Hemorrhage.
Okay, good, hemorrhage, okay? Client with colostrum discharge from both breasts. When do we expect the milk to come in?
after birth.
After birth.
About
Yeah.
4 to 5 days in, right?
Mhm.
Yeah.
Okay, colostrum will be there, and then the milk will start to slowly come in a couple days. All right, lochia, that is red. How long should the lochia be red? It should never have a smelling odor, right?
Up to
How long-
72 hours, I think.
Pinkish color.
24 to 72 hours, something like that.
Okay, so it's going to be red, and then it's going to go to a brownish
Yeah.
red, and then it's going to go to white. What happens if it, after it goes to white, it goes to pink or red again?
That's a problem.
Hemorrhage.
Okay,
And
we have
that's-
to look. And that's when that sub-involution or something else could be going on, and we have to take a look at it. So once
Mhm.
the lochia goes white, it should never return back to that other previous color. So 1 to 3 days, it's going to be red, then it's going to start to go brown, and then it's going to go towards white. And actually what that represents, that's excreting that endometrial lining. It's getting rid of that tissue that was broken down, and it's help removing it from out of the body now. The nurses provided discharge instructions to a client who recently delivered a healthy newborn by C-section. Which statement made by the client indicates a need for further instruction?
1.
1.
Okay, good. We already talked about this, right? So
Mhm.
we would want the person to do those other things there. They shouldn't be lifting anything heavier than the newborn. they should use their arms and stuff to lift up, because that will reduce trauma on the stomach, any surgical incisions that they might have. And we would want them to notify the physician if they develop a fever. So that is how you would rule that out. After a precipitous delivery, the nurse notes that the new mom is passive, touches the newborn infant only briefly with her fingertips. What should the nurse do to help the woman process the delivery?
Encourage the mom to breastfeed.
Yeah, two. I mean, yeah, one.
Okay, so the mom is right now is in the taking in phase. Okay, so remember, she needs support here. She's going to be totally dependent on the nurse. She had this baby really fast, and now she's like, oh my God, it's over. The baby's out. So now the focus is all on the baby. Mom's not, no focus here on mom, because, oh, what a cute baby. The baby's so cute. How's the baby? Nobody's asking mom about her, right?
Mm-hmm.
So this is really about the mom. Remember, she's in this dependent stage. She needs you as the nurse to give her what she needs for herself. So that's going to be 2. You need to support mom here. Everything else, if you notice, is about the baby, except for 4. And 4 is not really an option here. All right, so it's going to be a fast labor. Mom's going to have this feeling of disbelief, and she's going to need support. The nurse is monitoring the client in the immediate postpartum period for signs of hemorrhage, which sign, if noted, would be an early sign of excessive blood loss.
An increase in pulse rate, not the temperature, because the
Okay, because for
temperature.
a temperature of that, what are we going to do?
Normal, nothing,
It's
doctor.
normal.
We're not
I
gonna
mean,
do-
increase hydration.
We're not going to do nothing for that temperature?
Increase
No, we're gonna give
hydration.
them
Hello?
hydration.
Increase
Increase
hydration.
Increase
hydration.
fluid.
Okay.
And then number 2
4.
is
Would we expect to see 4?
sepsis.
Probably not going to see 4, right? Or if it's okay, there's not a problem there. 18 to 22, it's okay. What about 3? What about this drop in blood pressure?
That's
Well,
Well,
also
it's not really that low though. The one,
it has to be 10 by 10, I think.
yeah, it's only like by what,
Yeah,
6?
6.
Is that our first sign we would see if someone was hemorrhaging?
No.
Tachycardia is the first sign.
Okay. Good job. That's what I want to hear. All right, so the blood pressure, pulse, and respiration will be checked every 15 minutes, the first hour after the baby's born. The increasing pulse is the sign of excessive blood loss. The slight increase in temperature is normal. The blood pressure decreases as the blood volume diminished, but a decreased blood pressure would not be the first sign of hemorrhage. And then the respiratory rate is slightly increased from normal. So, but still not our biggest issue of concern there. The mom is preparing a list of self-care instructions for a postpartum client who is diagnosed with mastitis. Which instructions would be included?
Wear a supportive bra, because you want them to keep on getting their bra supported.
4. Need to breast you, yeah, you
5,
breasted.
5, because they're still taking.
I'm going to say no to 5.
No.
Why?
because they say the sore subsides. So you have to take your antibiotic until it's done. I'm sorry.
Good.
Don't you maintain fluid?
I definitely would. We're always giving fluids, guys, unless somebody's going to die from it because they're in heart failure or cardiac failure. I mean, kidney failure. We're always giving fluids, just about.
I think that's it.
What about rest?
Rest
Yes.
during the acute phase? No, you want them to continue breastfeeding, huh? Yes or no?
Well, what's rest got to do with breastfeeding? Let's see. I say they
Is it
need
rest?
Because it's
Miss-
painful
mi-
though, isn't
what-
it?
Oh,
You can't
rest
rest
during
while
the
you're
acute
breastfeeding?
phase? I'm sorry. Can you just explain to me why rest during the acute phase is important during breastfeeding?
Well, first of all,
Mastitis.
you're not going to be breastfeeding every second of the day. Can't you rest in between the breastfeeding periods?
Mm.
So if my patient has inflammation and all that, I'm going to want them to rest because that's going to help the body repair itself.
Okay. That will throw me off. I'm sorry.
Anytime my client is sick, I'm going to want them to rest. Your body needs to rest. When you do active exercise, that increases your metabolism. And if you're trying to heal your body, okay, you're increasing fluids, you're taking antibiotics, your body also needs rest to repair itself. You're not resting while you're breastfeeding, you're resting in between. So the baby doesn't breastfeed 24/7, right? It'll breastfeed every 3 to 4 hours. So in between those cycles, you are going to rest. Daddy can get his butt up off the couch and help. All right, the nurse is providing instructions about measures to prevent postpartum mastitis to a client breastfeeding her newborn, which client statement would indicate a need for further teaching.
Or you don't use soap, do you? You said you don't
Yeah,
use soap,
no
right?
soap.
So it's or
Correct, we do not use soap. We do wash our hands before we feed.
yeah.
We do feed every 2 to 3 hours. We do change the breast pads frequently, right?
Mm-hmm.
The postpartum nurse is assessing a client who delivered a healthy infant by C-section for signs and symptoms of superficial venous thrombosis. Which sign should the nurse note if superficial venous thrombosis were present?
Three.
Okay, why wouldn't it be 1?
Illness, that would be that's no, that's not because it says superficial. I mean, we could see it.
Oh, I would expect 1 to be more arterial since it's talking about color.
Wellness, yeah. And
What about 2?
coolness too. Coolness
Coolness
is
is
arterial
also
too.
arterial.
Right?
Yeah.
Yeah.
Okay.
Arterial.
And what about 4?
It's you should be able to palpate the
Palpate, yeah.
cells.
Okay. So for those of you that didn't know the answer here, you should have been able to eliminate those choices. And that's why I'm going through each one of these for the people that weren't able to do that. This is to show you how to get to the right answer. Think about those choices and why they're not the best choice. Don't look for the right answer because the right answer is going to make you take wrong choices. Nurse is preparing to care for 4 assigned clients. Which client is most at risk for hemorrhage? Looking for 2 or more risk factors here.
Hours ago, multiple delivered 6 hours.
Three.
Okay, I like 3. Why? 3 has what?
Because it's a month.
Oxytocin.
Yeah, and she
And
has
the baby's
Large
blood.
baby is my first clue. The second one
Mhm.
would be the
It's
oxytocin.
oxytocin.
And you have a client that's had multiple births.
Mm.
1, I don't see anything in there that indicates anything, or 2. So I would have eliminated those choices right away. And epidurals, as far as I know, would precipitate me more to a blood clot, headaches, those kind of things, as opposed to hemorrhage. So I would eliminate that because of that. I know that large babies can cause for difficult labor and problems. And I know that oxytocin, if it's added, sometimes can cause issues. So right there, I have 2 risk factors. The postpartum client is diagnosed with cystitis. The nurse should plan for which priority action in the care of the client. So first of all, you got to determine what it is.
It's inflammation of the bladder. I mean, infection of the bladder.
And
That
then
should be
how can you
polio.
best help this client.
Encourage the
I would
fluid.
say 2. I would say 2.
Okay, good. What is 1 for?
One
for-
is probably do with the episiotomy, like to
Okay, so the episiotomy, we might use it for any
for
sort of,
hemorrhoid. We can use it for hemorrhoid.
we might use it for hemorrhoids.
Mhm.
3 is going to basically be used for the same thing, swelling, edema, or a hematoma on that perineal area. And 4 is for what?
If we suspect bleeding, hemorrhage.
Okay, hemorrhage, good. So that leads you back to 2. All right, lots of fluids for this. Because it's an infection of the bladder, we're going to want to push those fluids. Nurse is monitoring a postpartum client who received epidural anesthesia for delivery of a vulvar hematoma. Which assessment finding would best indicate the presence of a hematoma?
Is it signs of heavy bruising?
No,
Is it 3,
no.
4?
How about vitals?
It's 1 because you guessed everything else. So you will see heavy bruising, okay, but you don't always see bruising. All right, you could have a hematoma, and you're going to look at the vital signs. All right, the woman, if she did have epidural, is not going to be able to feel pain, pressure, or the tearing sensation. The nurse is creating a plan of care for a postpartum client with a small vascular hematoma. The nurse should include which specific action in the first 12 hours after delivery?
Ambulation.
Is it 4?
Okay, so I hear ambulation. Why would we not do that?
Because
That's 12.
It could increase the risk for bleeding.
yeah,
Why would we not do 2?
because you should assess it like often than 4 hours.
More
Oh,
often
like
than every
4
4
hours.
hours. Okay, why
Yeah.
would we not do 3?
That would be more frequent.
Because same thing as 3, you should assess it like often, not every 4 hours.
Plus, it's also not going to make it, right? The
Okay.
fundal height is not going to have anything to do with the vulva, hematoma. And then what about 4?
I
On
would
the
do 4.
hematoma, 4 should help, right? It should
Yeah.
be swelling and take it back to normal.
Right.
On assessment of a postpartum client, the nurse notes that the uterus feels soft and boggy. The nurse should take which initial action?
1.
Massage the fundus. Somebody be
Whatever.
ask you about that because that's your standard answer for everything, right?
Mm-hmm.
That's the only question I remember from OB. Massage the fundus. On the second day postpartum, the client complains of burning on urination, urgency, frequency of urination. A urinalysis indicates the presence of a urinary tract infection. The nurse instructs the clients regarding measures to take for treatment of the infection. Which client statement indicates the nurse the need for further instruction? Further instruction. Okay, yes, probably 4 because usually we use acidic foods for this. So I'm going to say 4 is probably correct, but let's look at the other ones. I need to urinate frequently. Yes, we want them to do that, right? No?
Yeah, you don't want him holding the fluid. I mean, the urine.
Okay, we would have to take, if it was antibiotic, we would have to take it until it's finished.
Yes.
And we would definitely want them to increase their fluid intake. So 4 is the only one that makes sense here. And again, the reason why this is wrong is because we usually have foods. Remember, acids kill bacteria. So we would want something that acidifies the urine, not alkalizes it, okay?
Mm-hmm.
A pregnant client is admitted in labor. The nurse assessment reveals that the client's hemoglobin and hematocrit levels are low, indicating anemia. What should the nurse observe for following the client's labor? What should the nurse observe for following the client's labor?
1.
I would say infection. They don't have enough. I mean the red blood cell and then hemoglobin, the oxygen in the blood.
Okay, great job. Okay.
Blood cell.
Anxiety should decrease really after the baby is born, I would think. And I don't see that anemia really has much to do with the anxiety itself. It wouldn't cause that. I would expect the client to be cold if they're anemic, not hot. So I probably wouldn't be looking at that. And I don't see where low self-esteem really has anything to do with the H and H. So for me, the postpartum infection demonstrates that they might have some heart issues. The heart might not be functioning as well with this anemia. Okay, and so that's going to put them at risk to not heal as good. And so then we have to think about infection. All right, so anemic women have a greater likelihood of cardiac decompensation during labor, postpartum infection, and poor wound healing. Anemia does not present a risk for hot flashes, and anxiety and low self-esteem are not also related to the anemia. Methylgonavine has been prescribed for a woman at risk for postpartum bleeding in the immediate postpartum period. The nurse prepares to administer the medication, ensures which priority item is at the bedside.
Is it blood pressure cough? Blood pressure cough, peripad,
Okay, why the blood pressure cuff?
because metallogovin affect your blood pressure.
How does it affect your blood pressure?
Hypotension, drop the
A
level.
vasodilator.
So no, that's not correct. All right, what's going to happen is this is an oxytocin, a type of oxytocin or an oxytonic agent. Okay, so what's going to happen is it's going to cause the uterus to contract. And as it causes the uterus to contract, it can elevate the blood pressure.
Blood pressure. Okay.
That's why you want the blood pressure cuff there. You're looking for hypertension.
Okay. Thank you.
You're welcome.
So it is an oxytoxic agent. To elevate, okay.
So if somebody has high blood pressure, you wouldn't want to give this medication.
So I was kind of in the route of saying it correctly, Miss Sue?
I
said that it raised.
Drop the blood pressure. That's what I was
It-
hearing.
Okay.
It's not going to drop it. It's going to raise it. So if somebody
Raise it.
already has hypertension, we're not going to probably give this. The nurse is assessing a client for signs of postpartum depression, which observation, if noted in the new mother, indicates a need for follow-up or further assessment related to this form of depression.
Cannot be one because the mother is involved in the child. Cannot be two, the mother because they are demonstrating interest in taking care of the baby. Could be three.
It's 3.
Because she always complaining that she's tired, so she don't have no interest of doing anything for the child. And cannot be 4 because she's looking forward for the father to visit.
That's that's the first sign for lack of energy for depression.
Okay, good. A postpartum client is attempting to breastfeed for the first time. The nurse noticed that the client has inverted nipples. Which nursing action should the nurse take to assist the client in feeding the newborn?
I'm between 1 and 2. I don't know.
How about 4? We need to if they're we need to make them soft, right? I would say.
No, invert meaning that it is inside.
L. Yeah.
So
Oh, okay.
so I'm in between 1 and 2. I mean, 4 could be, but I'm in between 1 and 2. To get, have the mother grasp her hair between the thumb and 4. I'm going with 2.
Okay, so number 1 is usually something that we use if the breasts are engorged. So it's not that. Number 2 is going to cause, I think, the nipples to invert even further. So I wouldn't do that.
Okay.
So now I'm between 3 and 4.
Well, I'm
Judge
going,
Judy
If
shower-
breast
says
pumped,
what
it will
makes the
be,
most sense is probably true.
said what?
Judge Judy says if it doesn't make sense, it's probably not true. And the one that makes the most sense is probably true.
But
And
if
then
you
number
use
so
a
three,
I
pump,
guess,
hold on. Number
if you
two
use,
will even make it more, not to, the milk to come. I think number 4. would work.
yeah,
So
because if you
number
use,
3 is not much going to affect the nipples, but it might affect the ability of bringing the milk down.
It's a cold,
yes,
a cool water
Because
shower.
cool
system.
water is going to affect your ability for the milk to flow down, right?
'cause
Yeah.
it's ice,
Yes.
yeah.
So it might not be the best choice.
Yeah, 4 is maybe.
If the nipples are easier to grasp, number 4 says the nipples will be easier for the infant to grasp. That's
okay,
what I would want them to be, right?
okay.
Easier for the infant to take hold of them.
Provide. Oh, breast shield. Huh.
Okay. A new mother is seen in the clinic 2 weeks after giving birth to a healthy newborn. The mom is complaining that she feels as though she has the flu and complains of fatigue and aching muscles. On further assessment, the nurse notices a localized area of redness on the left breast and asks the mother and the mother is diagnosed with mastitis. The mother asks the nurse about the condition. The nurse should make which response? So let's look at 1, mastitis. Does it usually involve both breasts or can it be unilateral?
It
Can
can
be
be
unilateral.
unilateral.
Okay. Can it occur anytime during the breastfeeding process?
Yes.
Okay, so we like that one. Is it caused by wearing a supportive bra?
No,
Okay. Is it most common for women who have breastfed in the past?
no.
No, just correctly.
Okay, good. The nurse is developing a plan of care for a client recovering from a C-section. Which action should the nurse encourage the client to do to prevent thrombophlebitis?
Move around.
Ambulate
Yes.
frequently.
3,
Ambulate frequently?
Yes.
The nurse performs an assessment on a client 4 hours postpartum. The nurse notes that the client has cool, clammy skin, is restless, and excessively thirsty. What immediate action should the nurse take?
Cool, clammy, and restless. And thirsty. Right,
clammy skin.
4 hours post.
You want to assess hypovolemia.
She is going into maybe a shock because
Yeah.
cool skin. Cool.
3,
Why 3?
because she is restless. She might be hypoxia. So we need to elevate her the head and
So
check.
we're gonna elevate the head if she has hypovolemia?
I'll do 4.
No, hypoxemia.
I mean, she has cool, clammy skin and she's restless. To me, that's signs of shock or going
Yeah.
into shock, which is a decrease in body fluids, which would be a hypovolemic situation. So am I going to elevate the head in this situation?
No, because she's not
4,
having
4,
trouble
I'm sorry,
breathing, though.
4.
Well, no, let's talk about elevating the head of the bed in a hypovolemic situation. What is that going to do to the client?
It's usually you do the reverse, right? You like you
Right, you put the head down
yeah.
and lower the leg and
Yeah.
increase the legs, right?
So
Yeah.
that
That's why
the
it's not going to be 3,
yeah.
right?
Yep.
Yeah.
Okay. Remember, you have to recognize shock in these ladies.
Yep.
You can leave that open if you want. Everybody's pretty much gone. You too. Okay, nurses monitoring a postpartum client in 4th stage of labor, which finding, if noted by the nurse, indicates a complication related to a laceration of the birth canal.
Laceration, presence of dark red lochia that's expected, palpation of uterus as affirmed, that's good, saturation of more than 1 peripad 1 hour.
3.
3.
3, because that's a lot of bleeding. Saturation of 1 peripad 1 per hour.
So why is it not B?
Why is it not what?
Why is it not B?
That's good, right? Palpation of uterus as affirmed.
Why is it not 3?
No, B. Oh, 2. Somebody,
2.
okay, you guys
Oh,
said
I was
3, not B.
outpatient of the uterus.
You said 3, not B, right?
I said
He said
3.
3. Yeah.
Okay, that's why I'm asking, because I thought somebody said 2, and I'm thinking they said B.
No,
Why is it not 2 though?
because it says laceration of the birth canal. I mean, that it's you know, in their vagina. You have to look for the cut or whatever that is, laceration. Palpation of the uterus as a
Pharma is good, I think.
I will look because it says laceration of the birth canal. I will look in their vagina. I mean, rather than look in the.
So it's not 2 because 2 is normal. All right.
Yeah.
In the first 24 hours, the uterus is going to be firmly contracted. It's going to be about the size of a grapefruit or a softball. So that's why that's wrong. How about 1?
About what one?
Expected. Red and
1, presence of dark red lochia.
Yeah, it's red, dark red, and then white, right?
So in the beginning, we would have a dark red of a moderate amount, right?
Mm-hmm.
Okay. And why not 4?
Palpate
That
of
is-
the fundus at the.
that is in pregnancy. 20 week of pregnancy, palpation of fundus at the level of umbilicus. Yeah.
So you should also be able to locate it here now in this situation,
Mm-hmm.
because we're in the 4th stage. So then that
That's
brings you back to
expected.
3. What does 3 indicate? How many pads should we have in an hour? Or how long should 1 pad last?
More than an hour.
2 hours, I think. 2 to 4 hours.
The
Something.
saturate of more. Well, it could be
It's saturated, so.
a 3 because you cannot saturate more than 1 per hour.
Okay.
So 1 an hour is good.
Do you see how going through the choices, okay? Because otherwise it can lead you to make wrong choices. You definitely want to go through your choices well. All right, more than 1 peripad, even in the early postpartum period, is considered excessive. First 24 hours, the uterus should feel like a firmly contracted ball, about the size of a grapefruit or a softball. And then you should be able to locate the uterus at the level of the umbilicus. It's going to start to descend after birth by 2 breath fingers every day, right?
Mm-hmm.
1 to 2.
Yes.
All right. And then we expect the lochia to be a little dark here, just not an excessive amount. All right, last one, guys. The nurse is providing instruction to a client diagnosed with mastitis. Which statement, if made by the client, indicates a need for further instruction? I think we did this already.
Yeah.
Evacuation and repair of a paravaginal hematoma. A client is discharged 3 days postpartum. The nurse determines that the client needs further discharge instructions when the client makes which statement?
One is good, two is good. My husband and I will not have a
Oh, what if you fall asleep next to the baby and roll over? So 2, I would not do 2. Laying, you know. You know what I
Okay,
mean?
so for patients post-surgical, so 1's okay, right?
Yes.
2's okay because it doesn't
2 is
indicate that she's sleepy. She's just feeding the baby
ding, my husband.
and she's in a comfortable position. So I say it's okay. What about 3?
Yeah,
You have to wait for the
that's-
doctor to give you the, like, you know, okay, when to have sex. Like, I mean, when the stitches are healed.
Actually, how about 4? She can,
Why 4?
can she take any other medication, a pain medication?
Should she be taking another medication?
So we're looking for the wrong answer, right?
Yes.
Yeah, so I would go for.
We're
4.
looking for something that indicates that she needs further teaching.
Yeah,
I'll go with 3.
So I think 3 is wrong, and for a couple of reasons, but as long as the site is healed and there's no infection, 3 is okay. The husband typically should probably wait till the doc says it's okay, but we're talking about a husband here, okay? So when he's ready to go, he's gonna wanna go. Yeah, he don't care about your sutures or anything else. He'll be trying to find other body parts that work. All right, what about 4? 4, she's gonna need an antibiotic because she's post-surgical, right? And postpartum. Got a lot of stuff going on here.
Yes. I'm gonna go with 4.
that makes sense.
And I always make it a joke, but when you're talking about sexual favors for the husband, one thing that you have to always consider is our doctor might want one thing. All right. He's got his own way of thinking. So you don't want to tell guys they got to go 6 weeks without sex. That'll kill them right there. So we find other ways around that, right?
Nope.
All right. Questions, guys?
Tomorrow, what time tomorrow?
8
8
o'clock.
o'clock? 8 o'clock, okay.
Peds, and we're going to do the neuro and skin.
Yes, thank you.
All right.
Have a good one.
Oh, Miss Sue,
Use your link
Miss
from
Sue, I have a
today,
question.
okay?
Hello?
Yes.
I have a question. Wait for the test on Tuesday, right? Because
Uh-huh.
I emailed Miss Clark and she didn't actually email me back. Because the syllabus said the exam is in anything after, like, you know, the last chapter that we did, which is skin, that will be like 3 chapters only. So since Monday, there's no school on Monday, but if there were school, we would have done chapter 44 and another chapter, 2 other chapters. So I'm trying to figure out if those 2 chapters gonna be in the test. You know what I mean? But I
Oh, did she send you the email I sent her?
no, that was
That's for
OB.
OB.
That's the wrong one.
She
We are
sent
asking about peds.
she
All right, I'm gonna
sent
tell you what.
something
Let me
about
stop
OB.
my screen share, and then I'm going to tell you what chapters are going to be on there.
Okay.
It's for exam 2.
Yes, I'm in
Yes.
3.
No, two. Pete's exam.
Two, yeah. Oh, yeah, sorry. I'm
Exam 2
counting
for
the
peds,
mid.
right?
Yeah,
Yes.
yes.
Miss Sadiq, I'll be right with you, okay?
Okay. I'm just learning the peak stuff, so it's interesting.
Can you guys see my screen?
No.
Not
Perfect.
yet.
I don't want you to, so that's good. All right, because you can't see what I'm saying. All right, these are not necessarily in the order, but I see chapter 45, chapter 37,
Mhm.
chapter 38,
Mhm.
and that's what I see.
Okay, thank you.
Those three.
So it looks like it's very heavy on those three, and there's a couple dosage calculations.
Okay, thank you.
Okay, so we'll try to cover those chapters tomorrow as much as we can. I guess those are the same chapters that you guys told me about.
Yes,
Okay,
Thank you, Miss Loesch.
thank you.
Thank you.
All right, thank you.
have a good weekend.
You too, thank you.
You too.
Tomorrow.
See you tomorrow morning.
See you tomorrow. Okay, Miss Sadiq, how you doing?
I'm good, Miss Loesch. How are you?
I'm good.
Miss Loesch,
Need help
when
with that care plan, right?
yeah, I do. When do the like I was told, I believe in the beginning, this Z says something about we were gonna be doing clinicals on Saturdays. Do you know when that starts for term?
Yeah, that doesn't usually start until around term 4.
Okay, and it's every Saturday?
It may depend. Like right now, they're doing every other Saturday, but once they actually get into the clinical setting,
Mhm.
it may be every Saturday.
And it'll probably be like that until the end.
Yeah, you'll be on Saturdays until the end.
Okay, all right. I'm just trying to manipulate my schedule at work, so that's all.
So if you want to go ahead and bring your care plan up for me so I can see it.
Okay. Well, let me see if I can find it because I'm on my work computer. So hold on, I can find it. I should be able to get it from my email. Okay. Can you see it?
Let me get back to the meeting. Yes.
Okay. Okay.
So PSH is social history.
Social history. Okay.
And then for your pain assessment, I need you to put 0 out of 10.
Okay.
Under nutrition, where it says type of feeding, I would like you to put oral there.
Okay.
And where you have the last the description of the abdominal assessment, that should say bowel sounds times 4 quads.
Okay.
That's how we know they're present and normal. So positive times 4 quads. You can scroll down. Well, actually, could you make this so it's 1 page, and then that'll make it a little more easier to read.
Okay.
I think, is she incontinent of bowels, or urine it was that she was incontinent of?
I did not see anything about a bowel movement. I did see urine output.
Okay, so let's just leave it as is. I'm going to take it like that.
Okay.
All right, go ahead on down. All right, unsteady for the gait. On the activity, you also need to put there, I would put her transfer with 1 assist.
Okay.
For cranial nerves, you can put not assessed at this time.
Okay.
All right, and then the next thing you got to go to is the psychosocial component. So for her body image, is it going to be disturbed at all because of this wound?
Yeah, it would be, and possibly disturbed because she did mention that she was overweight. So
Okay, so you could say, something along that line, like,
okay.
low self-esteem due to obesity or something along that line.
Okay.
Religion is Catholic, right?
Okay.
That needs to go in there. And then the Erickson stage, what stage is she in for Erickson's right now?
Okay.
She's in integrity versus, is it integrity versus despair? I think she's in. You can look it up for an 80-year-old, it'll tell you,
Okay.
or for the older adult.
Okay.
The role transition. So she was independent, and now she's going to dependent, right?
Yes.
And then who are her support systems? For one, she has her daughter and probably the Catholic Church.
Okay.
Usually they're pretty supportive. They come and see their members in the hospital. They have
Okay.
Catholic charities. So all those things could help her as she transitions into that dependent care role.
Okay. This was where I got stuck with the stimuli.
So her focal stimuli is the venous stasis ulcer.
Okay.
That's what you're using, and that's fine. Focal
Okay.
stimuli can change. So usually the focal is whatever brought them into the hospital or whatever caused them to seek treatment. And so some people put safety here because after she sought the treatment, now the concerns are sending her home alone. But yours is fine with the venous stasis ulcer. That's perfect.
Okay.
What would have led to that venous stasis ulcer? What kind of things in her life? That's conceptual. What kind of things in her life caused her to get this ulcer?
Well, it's definitely probably the immobility due to the weight gain, and it's probably it could be poor hygiene. It could be diet.
It is diet. I mean,
Yeah.
look at her albumin and her pre-albumin levels.
Yeah.
And what else besides the diet? The obesity is definitely an issue. What else?
Obesity, diet, the immobility.
The COPD,
Oh,
because of the tissue perfusion, right?
Okay. Yes.
So those are the conceptual factors, because these are precipitating factors to this venous stasis ulcer.
Okay.
Now, residual would be things that may be contributing to it that she's not aware of.
Okay.
So that could be like cultural, it could be genetics, it could be her age. I said culture, right? Her ethnicity.
Yeah. Okay.
And even the obesity really could be a residual for her, like there in the conceptual, you could be putting the immobility due to weight or due to inability to transfer on her own. And then for residual, you could actually put the obesity, because she may not be aware that because she's obese, it's reducing her risk to heal appropriately.
Okay. That makes sense.
For the medications, you have to have a nursing consideration or an indication for each one.
Okay.
And then for the labs, you only need the abnormals. So if there was any
Well, I think that,
diagnostic test or any lab done that was abnormal, it would go on there. But it's
Okay.
okay if you put the normals, that's fine. You just only need the abnormals to put on there. You don't have to put the normals. But if you
okay.
had anything abnormal besides the albumin or the pre-albumin, you would have to put it on here.
Okay.
Teaching and discharge. Okay, so what kind of teaching is she going to need?
Okay. So she's gonna need well, definitely it's gonna be how to clean it. Well, hopefully you would think that when she discharges that the ulcer is gonna be all the way completely healed.
Oh, it's not going to be all the way completely healed. No way. It's not. This is a
So
pressure ulcer. Okay.
okay.
What you have to
So-
think about is, for one, she has COPD and she's malnutrition status.
Okay.
All right. So this wound is not going to heal for probably a year.
Okay.
So what kind of teaching are you then going to do with her?
You're gonna have to teach her how to clean a site and how to change the wound and how often to change it.
Okay. So wound care teaching, right? How to care for the wound. What else?
You're gonna have to teach her diet, because she's gonna need to increase probably a lot of protein.
And besides teaching her how to eat a proper diet, what kind of resources could you refer her to in the community that might assist with this process?
She's gonna need a referral to a nutritionist, because she's
Okay,
probably eating the wrong things.
good. A nutritionist or a dietitian to help her.
Okay.
So these are the kind of things you're looking for. And besides the wound care, what other help is she going to need with this foot?
She's probably gonna need somebody to help her put the daggone the stocking on. I don't even think she probably can do that.
So at least PT, OT referral, and we might give her a referral for home health care.
Okay.
So this is about discharge needs that are related to what's happening to her. So all these things are going to help her survive once she gets out of there. Really, she would need a home care evaluation anyway, because if she's not able to make her own transfer, she wouldn't be a candidate for living safely in the home. In order for you to live safely in the home, you have to be able to transfer yourself appropriately. So someone would have to go in and make sure the home is safe, make sure she could do those basic things for herself, and then maybe consider her going to stay with the daughter or somewhere else until she can do these things.
Okay. Okay. And then this was where I really got stuck at, because I was like, I remember you saying that something was supposed to be copied and bought from, was it the focal stimuli and stuff was supposed to be copied and brought over into this page?
So correct, your focal, contextual, and residual stimuli, once you fill that in at the top,
Okay.
that will be transitioned over to the bottom, just copied and paste. Now, for observable versus non-observable. So
Okay.
what non-observable signs does she have?
The non-observable.
And that would be any complaints that she made that you can't physically see. You can't see her pain, right?
She said she didn't have any pain when I did the thing. She said she had.
That's a non-observable sign, right? Denies pain.
Okay. Okay.
What other subjective symptoms did she have?
let me see if I can remember. She said she had no pain. She refused water. I clicked the button to say, what brought you here today? And she said that she had a sore on her leg. She kind of denied that she was taking any medications besides the vitamins. She's like, I only take the vitamins. But then when I was looking at her medication record, she had vitamins, she had albuterol. She said she was a smoker 30 years ago. She also said that she had COPD. What else did she say? She has COPD.
So you wrote on your contextual phocoresidual that she was easily fatigued. Did she tell you that?
She said she's been getting tired lately.
So that's another subjective statement there, right?
Okay.
So easily fatigued, states pain is 0 out of 10. So those are your subjective. Now, what about objective? What can you physically see?
You can see the pressure ulcer.
Okay, so you can put that on there. What else could you physically see?
Well, she doesn't look well. Like, I don't know if that was just a picture, like if that was how she really looked. I mean, other than the fact that she was like obese and she's very short,
So
she
you
doesn't
could put
look
her
well.
BMI on there. That's actually, would make sense. You could put her COPD on there because that can be measured through an X-ray on there. But that's not really a behavior.
Okay.
But I would put the pressure injury on there because you could see the impaired skin integument there.
Okay.
So you could put, impaired skin integument of the heel. You could put that she requires a 2-person transfer and that she has an unsteady gait because you can see that.
Okay. Okay. So then we get the nursing diagnoses. Those,
So you have impaired skin integrity, right?
yes.
Related to what?
Related to client being immobile.
Okay, so related to immobility and decreased tissue perfusion, right?
Yes.
As evidenced by, so your pressure ulcer of 3 by 4 by 5 is one of those things, right?
That like I could not find the size of this wound anywhere. I looked in that chart so many times. I kept
Really not
trying
there.
Oh, okay. Because I was like, I know you said in class you was like you need the size of the wound, and I'm like, where's the
I
size of
didn't
this
say it
wound?
because I thought that the size of the wound would be included, but I don't think it was. So if you don't have it, you don't have it.
Okay.
Can't put what you don't have there.
Okay.
So you could just put large pressure wound. And is it stageable? Did they stage it as a
They
stage?
don't. It's not staged. And there was nowhere inside of the I looked everywhere. I didn't see no staging anywhere. The only thing that I could get out of the thing was just that it had a hydrocolloid bandage. That was it.
Okay.
Yeah.
So you can just put due to large pressure wound on heel.
Okay. Okay. I'm not sure why my second link didn't. The first one was looking like the second one.
Just
but
put your cursor there behind the last and then hit enter.
Oh, okay. Okay. All right. And then my evaluation goals, those are like what I would want to have before
So
client
where
is
your
discharged,
cursor
right?
is now is going to be interventions. Okay, so
Okay.
what kind of interventions would you do for the impaired skin integrity? Is this going to be your primary nursing diagnosis?
Yes.
So what kind of interventions would you do for impaired skin integumentary?
I
And
would,
so here I would, let me just see your remote for a minute.
okay.
It's not working. Click on that link for me.
Which
Not
one? This link to go back to the handout?
Nurses Labs.
Oh. That wasn't even open. Hold on. Here?
Yeah, it should open when you click on it. If you use control and then click.
Yeah, I don't know what's going on. Oh, wait a
There it
minute.
goes.
Is it going?
It's
Okay.
trying to go. You might have to do a new share and show me your desktop for us to see it.
Okay.